Good evening, everyone. Tonight is going to be I will try to make it as simple as possible for tonight's session, and just some feedback from those that joined the Terengganu mock. Right, can see that some of the questions are quite, I would say, direct and straightforward. And it's always good to actually practice cases that is a bit tough, so that when you are in the real exam, you will feel more confident to handle. Okay, before we start, again, back to the same old slide that we always go through. Please give yourself adequate time for history taking, 8 to 9 minutes, and then only then you examine the patient for about 3 to 4 minutes, and then when the examiner tell you 2 minutes left, only then you address the concern, and the remaining 5 minutes is to with the YY session. But but you have to be prepared that every scenario when you prepare the scenario outside, you must write down list of possible differential diagnosis as you go through the scenario, and always write down things that you don't want to miss in the exam. Okay, with that, Dr. Abi, are you ready?
Yes, doctor, I'm ready.
Okay, so I will give you 4 minutes like usual instead of 5 minutes to prepare. Is it okay? Hello, Dr. Abi?
Yes,
Abi, yeah?
doctor.
Yeah.
Yeah,
Okay, I will start the timer now. You have 4 minutes.
yeah.
Okay, time's up, Dr. Happy. This is the patient, Miss Cheng. You can start now.
Okay. Hello, my name is Dr. Rabi, one of the doctor in this medical outpatient. Is this Miss is this Miss Chung, 32 years of age?
Yeah, this is I'm Cheng.
Okay, how may I address you today?
Sorry?
How may I address you today?
Yeah, just call me Miss Cheng.
Okay, Miss Singh, we're here to discuss about your health condition. I will be examining you and then we'll be able to address your concern. During our discussion, I'll be taking some note and I promise it will remain strictly confidential. Is that okay for you, Miss Singh?
Yeah, sure.
All right, Miss Singh, I understand that you have come with the fever and joint pain for 3 months. Is that right?
Yeah,
Can you tell me more about your fever and joint pain?
Yeah, so doctor, I started to have fever about 3 to 4 months ago. It started gradually. Initially, I thought I just had some common flu because I do have a bit of runny nose and a bit of cough. But subsequently, I realized that the fever has been persistent. And if
Okay,
I also checked my body temperature at the day and also at the night is almost the same, ranging about 39 degrees to 40 degrees. And towards the
okay,
late evening and before I sleep, it tends to get worse. I tried to take some Panadol.
okay.
It seems to come down with when I took the medication, but after that it actually recurred. So this thing is quite troubling for me, doctor.
All right, Miss Chen, I'm really sorry about your symptoms and thank you for explaining me all about the fever. And can you tell me if your fever is associated with, like chills, night sweat, anything like that?
I do feel chills when I'm having fever, but not
Hmm.
really having any night sweat in particular.
Okay. And you told me that, the fever goes away with the paracetamol.
Yeah,
Okay, okay. And can you tell me about your joint pain as well?
Yeah, doctor. With regards to my joint pain, I have this very non-specific pain over my wrist, my ankle, as well as my knee. So this actually comes and go as well. Sometimes it occur in only left side, sometimes occur at the right side, sometimes occur at the both side, and it tends to change in different joints with different
Hmm.
time. So I cannot pinpoint exactly where am I having any pain if it's not like having actively pain.
Okay, so you mean the the joint pain moves around like different joint, different time, right?
Yes.
Okay, is it like small joint of the fingers or the large joint like knee joint, your shoulder joint?
Like I say, my finger is quite alright. But I usually encounter pain over my wrist, my knee, as well as my
Hmm.
ankle.
Okay, and have you noticed that on the both the arms, both the hand, both the leg?
Only my knees and the wrist, not over my arms or my forearms.
Okay, I mean it's on the both side.
Sometimes it's one side, sometimes it's both side.
Okay, and did you notice any stiffness in the morning?
Morning stiffness, sometimes I do encounter a bit of stiffness, but it only
Okay,
lasts less than 1 hour.
it lasts less than 1 hour.
Mhm.
Okay. And as the day progresses, do you feel more pain or you feel less pain?
I feel lesser.
You feel less pain as the day progresses.
Mm.
Okay. And have you noticed any like redness over your joints?
Redness as in my joint, no, doctor, but I've been
Okay.
having this rash, as you can see, over my hands. This is my forearm. You can see
Okay.
this rash is also like changing in location and sizes, so I it's quite bothering for me.
Is it painful to touch?
No, there's no pain.
And does it itch?
No.
Okay. And when you press it, does it fade away?
I'm not sure. Perhaps you can check it later, doctor.
Okay. All right. And may I know, Miss Sun, you have any sores in your mouth?
No.
Have you had any sores in the mouth in the past?
Not really.
Any problem in the vision?
No.
Any redness of the eyes?
No.
Any rashes in your face?
No.
Okay. And have you noticed any like change in the color of your fingers when you're exposed to extreme cold? Does your finger turn white?
No.
No. And have you noticed any skin tightness?
No,
No. Okay. And mm, have you noticed any problem in using your arms, like climbing upstairs, hanging clothes?
no,
No. Okay. And have you noticed any headache,
no,
any feeling of sickness in the morning?
no,
Okay. Any stiffness at the back of your neck?
no.
Okay. Any cough?
Cough, like I mentioned previously, I do have a bit of cough and runny nose, but it have already resolved.
It has already resolved. So how long ago you had cough, this flu-like symptoms,
I
as
think
you
one or
said?
2 months ago. 1 or 2 months ago.
1 or 2 months ago. Okay. All right. So now you don't have any cough.
No,
Any any sort of breath?
no,
No. Any chest pain?
no,
Any racing and pacing of the heart?
no,
All right. And have you noticed any like heartburn?
no.
Okay. And okay. All right. So can you tell me how is your diet and appetite
My appetite has been poor for the past 3 months, doctor.
past 3 months?
Hmm.
Okay. And how is your weight?
My weight is, I think I'm also losing weight.
You're also losing weight. Roughly how much have you lost?
I cannot really quantify because I didn't weight myself, but my pants are getting looser.
Okay. And are you on any diet plan?
Sorry?
Are you on any diet plan to lose your weight?
Oh, no, no, no,
No. Okay. Have you noticed any problem in your waterworks? Any
no,
bubbles in the pee, darkening of the pee?
no,
Any problem in your bowel works?
no.
No. Any weather preferences?
Not really.
Not really. Okay. And okay. Any lumps and bumps in the body?
I'm not sure though, because previously I do feel a bit of my lumps over my neck, but it have resolved.
Okay. All right. And do you have any previous medical condition, Miss Sun?
No, no, no. I'm previously healthy. This is the first time I come to hospital, doctor.
Okay. And have you had any previous operation or
No,
surgeries?
no,
No. All right. And may I ask you, are you taking any other medication except this paracetamol and all?
no,
Okay. And any unprescribed drugs over the counter?
not,
Any drug allergies?
not that I know of.
Okay. And I am sorry for my next question, a bit personal question. Are you involved in any party drugs or any recreational medication?
No, no, no.
No. Okay. And may I ask if you have any disease that runs in the family?
Not really.
Okay. And uh, do you smoke?
No, I don't.
Do you drink?
No. You mean alcohol?
Uh,
No.
yeah, all good. No. All right. So if I may ask, what do you do for a living?
Yeah, doctor, I work as a promoter, promoting mainly bank credit cards. And this thing has been bothering me a lot because I have this rash and also have this fever. I really don't feel well to go to work at all, doctor.
Okay. I'm really sorry, Mr. John, but hopefully I can help you by the end of this conversation.
Mm.
And so, Miss Chen, I need to ask you some more private question. Is that okay for you?
Okay.
Miss Chen, are you married?
No, no.
And do you have any casual partners?
Not really casual. I'm staying with my boyfriend. I'm only with him.
Okay. And are you taking any birth control pills?
No.
Okay. And when was your last menstruation period?
My last menses about 1 week ago.
1 week ago. Okay. All right. So, have you traveled in anywhere recently?
No.
Have you been in contact with somebody who is like coughing or who looked sick to you?
My customer, I'm not sure, but among my colleagues, I'm I don't realize it.
Okay. All right. And may I ask you if you have any problem in your private part, any discharges?
No.
No. All right. Thank you. So is it okay if I examine you, Miss Chan?
Yeah, sure.
So all right. So first of all, I will inspect her RAS.
Sorry,
This
where?
one's the RAS. RAS, right? This one is the RAS.
Yeah, rash, you mean? Yeah, oh,
So
this is the
yeah,
forearm.
is it form? It's blanchable.
It's non-punchable.
It's painful.
No.
It's only in this forearm, right? Not in any other place.
When you check further, there's also a rash over the thigh region,
Over the
right
thigh
right side.
region.
Yeah.
Over the thigh and the right side.
Hmm.
Okay. And can I start by looking at the hands?
Yeah.
So I will check for any nail changes, any clubbing, and I'll also feel the joints if it's painful.
Non-tender, there's no joint active synovitis. Fingers looks normal to you.
Okay. And can I check the pulse?
Okay. Pulse is regular, good volume.
Volume. Okay. Um, and is there any calcinosis, anything in the fingers?
No.
No. Okay. And now going on towards the eyes, looking for any pallor.
No pallor.
No pallor. Okay. And looking for mouth, any problem in mouth opening, any tightness,
No.
any tight skin on the nose,
No.
a tight skin on the hands, arms.
No.
No. Okay. And looking for the lymph nodes on the neck.
Yeah, when you palpate for her lymph nodes, there is a palpable left cervical lymph node, measures about 2 cm, non-tender. It's quite mobile.
Quite mobile, non-tender. Okay.
Mm.
And now I will listen to the lungs.
Okay, lungs, when you listen, it's equal breath sound, no bronchial breathing, no crepitation.
No bronchial breathing, no crepitation. And heart for any rubs, any murmur, any loud P2.
Mm-hmm. When you the heart's S1 S2 is heard, there's no obvious murmur.
Okay. No, just murmur. Okay. And I'm going to check for elbow joint and knee joint if there is anything, any painful joint
No,
and any tender.
there's no joint tenderness.
Okay. Don't joint tenderness. Okay. I'll also palpate the abdomen for any liver or
Okay,
spleen.
2 minutes left. Which area you want to palpate?
I will palpate the abdomen if any tenderness, any liver enlargement or any spleen.
As you sit down, lie the patient on the bed, and then you are going to sit down on the chair, and then you start to palpate. You don't feel any obvious palpable liver or spleen.
Mhm. No splenomegaly.
No.
Okay. All right, Miss Chen, thank you for letting me examine today. May I know what are your concerns for me today?
Doctor, what am I having, doctor?
Uh, Miss Chen, I've examined you, and from our examination, I think you have some infective cause of we call it migratory polyarthritis. So it is basically, your body is responding to some infection that you probably may had from the earlier infection that you had that is causing this joint pains and the rashes that you have. Okay, I may need to run some tests in order to confirm the diagnosis for you, and then following that, I will be managing your condition. Is that okay, Mr. Chun?
Doctor, do I need admission?
So at the moment, I don't think we need to admit you because your vital seems quite stable. I will give some pain medication and some will run some tests, and then as soon as we get the report, we can call you for the follow up.
Doctor, is this condition curable?
Uh, yes, Miss Chen. To be sure that I will have to confirm the underlying diagnosis, but however, it seems to be some infective cause, which may be most of the time it is a curable condition.
Doctor, can this be cancer?
Um,
Time's up.
Mission, after
Yeah.
examining you, I don't think so. It you have any symptoms that demonstrate cancer, so
Okay.
which is less likely for you.
Okay, Dr. Api. Okay, let's stop now. So let's discuss about this patient. What is based on what you have gathered? What is your differential diagnosis and your provisional diagnosis?
Uh, for this patient, after examining, I think it's kind of a reactive arthritis following the uh, post infection like Epstein-Barr virus.
Mm-hmm.
Mm,
Is there any other
and
differential diagnosis?
yeah, my other difference is autoimmune disease like SLE,
Mm-hmm.
um, and mixed connective tissue disease. But however, the patient did not have any Raynaud phenomenon, anything like that.
Mm-hmm.
So
Any other differential?
uh, the other is the patient denied history of any unprotected sexual contact. I may also think about uh, gonococcal arthritis, but
Mm-hmm.
there was no any significant history. And the other thing that I can think is rheumatic fever as well.
Okay. All right. So how do you investigate this patient?
So for this patient, since the patient had flu and all, so rheumatic fever should be considered in this patient. So for this, I would like to perform blood test, including complete blood renal liver function test, as well as ESR-CRP for this patient, and I'd like to perform the EKG for this patient, and echocardiography to rule out if there is any vegetation. I'll also perform a blood culture, which should be done at least 3 sets of culture, different sites, 12 hours apart, and I'll also perform X-ray imaging of the large joint, the knee joint. Which the patient has pain, and mm, to rule out any other causes of for the gonorrhea and for STD, I will do a urine PCR for gonococcus and chlamydia, and I'll also like to do a monosport test for this patient to look for Epstein-Barr viruses, possibility of that, and mm, 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 mm.
Anything else? You have mentioned you want to screen for things like SLE.
Yeah, I will perform ANA, perform dsDNA for this patient.
Hmm.
I will also perform ASO titer for this patient.
Okay. Anything else you want to order for this patient?
Mm, 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 mm. So I couldn't find the possibility of any other connective tissue disorder like MCTD and CREST syndrome.
Mhm.
So I will not. I think I will not look for that.
Okay.
Uh,
So
I will
let's
also
say
look
that
for serum calcium level and all. Yeah.
okay. So let's say that this is something like a migratory polyarthritis, like you mentioned, and it's like autoimmune kind of nature. And what is your aspect of management in general?
So in this case, the rheumatic fever could be my top DD, and in this case, I would manage with um, uh, with NSAIDs and paracetamol for the joint,
Mm-hmm.
and I will look for underlying involvement of the heart and bones as well, and the joints as well. So if there is heart condition, if there is any signs of heart failure, then I will manage accordingly with the ACI, ARB, diuretics, and all.
Okay.
Mm, and I will, s- I would, I'll basically keep the patient under follow-up.
Do you want to refer to anyone?
Yeah, I will refer this patient to the cardiologist, also for the orthopediction for the joint
Sorry,
and
orthopedics.
orthopedics. Yeah,
Any reason for orthopedic? They are not going to do any surgery, right?
just to rule out if if the joint pain is due to any arthritis, osteoarthritis. I mean,
The joint pain
uh,
is mechanical or inflammatory to you?
so it looks like inflammatory to me.
Okay, all right. Okay, that's all. Thank you, Dr. IP. Time's up.
Yeah.
Okay. So how do you think about your performance for this case?
Mm, I don't know, doctor. I don't think I got the diagnosis in this case.
Yeah, you can feel that this is how you feel when you feel like you didn't hit the diagnosis very well.
Mm,
And
mm,
but I think you have improved a lot from the previous session. I think from the first session we have together with you, you have improved a lot. You are very fluent, no? And but just to highlight a few things that you mentioned just now. Like I said, I don't like to use the word waterworks like urine issue. Right? You can just ask the patient that, do you have any troubles with passing urine? Do you have any,
Assuming.
yeah, do you have any frothy urine? Is there bubbles in the urine? Actually, frothy is not a jargon. Frothy meaning is just like bubblish, but we don't like to use the bubble urine. Urine's in the bubble. Okay. And when you ask about weather preference, I mean, I know we want to screen for the hyperthyroidism, but you should, I mean, because most of every candidate we mention like that is a very temperate thing. Just like, for example, by temporal hemianopia, how do you ask in the symptom? Do you tend to bump things at the side of the
Mm,
objects? Right? It's very temperate thing, right? But make it a bit more natural. Instead of saying, do you have any weather preference? So you can just say that, are you able to tolerate hot or cold weather? It
mhm,
means just a very simple sentence. I know you're trying to go by systemic review to screen for that, but certain history you can actually be more fluent and use the
mm.
more simple language. And why you suddenly stuck at the patient name to begin with?
I'm sorry, Doctor Zen. I didn't
When
get you.
you first started the conversation with the patient, right?
Yeah.
You forgot the patient name, is it?
Yeah, I wrote your name in the top in Dr. Zunmin class, and then I wrote
Yeah.
Miss
So
Zhang.
you have to be very, the first thing that you cannot do is to mention or forget the patient name. Either you mention the patient name wrongly or forget the patient name
Yeah,
is something that cannot be acceptable. Huh? So
yeah,
you
yeah.
must write down in your paper what is your
Mm,
role. Your role is a doctor in the outpatient clinic. Okay, and what's the
yeah,
patient name and age, and what's the presentation? That's the first thing you have to write. Okay, you cannot forget the patient name or mention the name wrongly, because that will give the first impression, very important first
yeah.
impression. Okay, so yeah, so do you think rheumatic fever is likely in this case?
Yeah, patient had fever and migrating polyarthritis, maybe
But how to explain the rash? Because rheumatic fever can have the so-called erythema marginatum, so-called.
marginism. Yeah,
But this doesn't look like marginatum rash kind of thing,
yeah,
right? What
yeah.
what does this look to you?
It's look. It may be some vasculitic or some viral rash.
No, 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 no. This is not vasculitic.
Mm,
Vasculitic is very different rash, which I can show you later on. This is
mm.
very patchy, right? It's a patch, right? It's a very patchy
Yeah,
rash, and it looks
yeah.
red or pinkish to you, right?
Oh, maculopapular.
I won't say it's maculopapular because it's like flat. It's not
Uh,
elevated. It's flat only,
okay.
and it's not
Mm.
really maculopapular per se. So this patient, how long has the fever already started?
Yeah, fever started for maybe how much? 3 months.
3 months, right? So if you approach this as a someone with some form of pyrexia of unknown origin, with this kind of rash and some joint pain and some uh palpable lymph nodes, what is your differential diagnosis?
With fever, with rash,
And some form of cervical limb adenopathy, what is your differential diagnosis?
we can think about lymphoma.
Lymphoma. Not wrong, not wrong. But
Mhm.
any, because she's very young, right? And then also female, you're thinking more to autoimmune disease, right? What kind of autoimmune disease that can manifest other than SLE?
Mm, sarcoid.
Sarcoidosis, you asked about hypercalcemia symptom which she doesn't have.
Mm,
How about the rash? If
mm,
I tell you the rash looks a bit like pink, right? Pink flat surface,
Mm-hmm.
something like a salmon kind of patch, kind of rash. What is your diagnosis?
Salmon patch. Mm, Kawasaki, no.
Kawasaki, this is too late to be Kawasaki,
Yeah.
but something quite close. It's actually adult onset Still's disease, no?
Oh, disease.
Salmon pink rash, right? Remember?
Okay. Salmon
Yeah.
pink, yeah.
Yeah. So let's just go through. If I'm going to mark you, because this station you did not do well, I mean you do well in the sense of excluding the differential diagnosis, but because you cannot get the diagnosis and therefore the clinical judgment, this part will be considered as borderline or even unsatisfactory. Communication, I think you are very good. I think is acceptable. Examination is okay, but I think for this station you you will start with history for quite some time. You examine patient only at about 10 minutes, not enough for the physical examination. Okay, so physical examination, I think you demonstrate a few signs, still consider okay, but your clinical judgment and your identical and your differential diagnosis will mark you down. So probably you will get about half of the mark for this station. Okay, so the key point in this patient is actually prolonged fever, joint pain, which is non-specific. And then, however, when you examine her, she have no active synovitis. When you ask history for the joint pain, multiple joint pain, the first question perhaps you want to ask, other than the location, how many joints involved, is actually to differentiate is a mechanical or inflammatory. You need to really tell yourself to do that faster, because I can see that you ask a lot of questions about joint pain, but only until towards the last few questions only you ask about the characteristic. So you want to differentiate whether it's inflammatory or mechanical, right? And then you want to ask about constitutional symptom, because fever is also part of the constitutional symptom. You want to ask about the rash. And yes, this patient has some flu-like symptom as well. And this patient also need to exclude a lot of differential diagnosis, because we know that if you want to give a differential diagnosis or a provisional diagnosis of what we call as ASOD, adult onset Still's disease, is a diagnosis exclusion, meaning to say you need to really exclude a lot of things from your history and your examination as well as your investigation. Only then you can for sure know that this is a ASOD. So you ask a lot of autoimmune question, I think it's fine. In fact, if also you ask, you almost forgot to ask about sick contact and travel history, but at the end you remember. And also because she is female, you also remember to ask about the gynae history, the female history. You asked about, but you didn't ask about menarche, right? You only ask about
No.
the last menses, and then are you involved in any so-called casual partners? But I don't like the way you mentioned that are you involved in any casual partners? It's a bit judgmental when you ask like that. So the more neutral way is actually to ask, are you involved in any relationship at the moment? Okay, then yeah. Let the patient tell you. Instead of say casual partners, that it's not very nice when you ask patient as a first question. Okay.
Mm-hmm.
So social history, yes, but you forgot to really ask about how this symptom affect the patient condition. You only ask about occupation. So actually, if you ask me further, I will say that because of this rash, I had to apply a lot of makeups. Okay, but that's not very important. It's just something to address the so-called concern if patient have. And when you examine the patient, you want to do a very quick rheumatological examination over the joint, over the skin, as well as over the lymph nodes, and also the eye, the mouth. Okay, and when you examine in detail, actually I cannot account for you to have a sign of hepatomegaly, although this patient actually has hepatomegaly, the way I calibrated, because when you want to do abdomen examination, it's already 2 minutes up and you just about to sit down and examine the patient. So even in real exam, you may miss a hepatomegaly as well. Okay, so this is just a
Mm-hmm.
lesson that you need to budget your time, especially giving good enough time for examination. Okay, so differential diagnosis, actually you need to really include hepatitis. Okay, I know that you include infected endocarditis, rheumatic fever, and also possibility of this HIV, because but there's not much of this risk factor, right? And autoimmune, you also mentioned about rheumatoid arthritis, good. SLE is also good, and also malignancy, because we can something that is serious and something that we should never miss. We should always include our differential diagnosis, okay? Because got palpable lymph node already, it's not wrong for you to suspect lymphoma, okay? The so-called B symptom, fever, weight loss, The only thing doesn't have is actually perhaps is night sweat lah, but that can be
Okay.
right. So malignancy like lymphoma, lymphoproliferative disease, something you want to mention, and because if you suspect this, definitely you want to really examine the abdomen early. Like after you check the peripheral examination, you should away go to the abdomen. Okay, before you even want to check, because that time I think you are suspecting more to rheumatic fever, i.e., you want to look for murmur. But rheumato, I mean for the lung, I can see that you want to rule out any chronic lung fibrosis,
Mm.
some form of bronchiectasis. But you know that this is less likely because she does not have any breathlessness, only like flu-like symptom which resolved few months ago. So you want to target your time. If you're going to choose between abdomen, respi, and cardio, you should choose abdomen first. Okay.
Mm.
It's not to mention that you only can choose one, but you need to examine one of the system that a bit more detail in order to get the sign that the examiner calibrated. Okay, so if you think this is a adult onset steel disease, you after and another thing about your presentation on investigation, you should mention the reason of ordering the test instead of just ordering. I want to order CRP, ESR. I want to order liver function test. So you should mention that I want to check Fruber picture, Fruber count to look for any leukocytosis, inflammatory marker including ESR, CRP, and ferritin, liver function test to look for any liver injury, hepatic screening, autoimmune screening, and you didn't mention about this, right? You forgot about that until we hint you. And I
Mm.
mentioned about ASOT, and septic
Mm.
workup. Want to take a culture, not wrong. 3 sites because suspecting IE, PBF, basically just to screen for any leukoerythroplastic picture. So if you think this is a adult onset steel disease, how do you diagnose ASOD?
And there is this major and minor criteria, clinical diagnosis.
What is the name of the criteria? Do you know?
Uh, no, doctor.
It's from Japan.
Um,
Cannot remember.
no, I cannot remember.
It's important because if you know the diagnostic criteria, only you can do well if this is really a case of ASOD. Lah. And ASOD tends to come out in exam as well. It's not that rare. It's something that is like PACES favored and expected cases. Certain cases, like for example, common variable immunodeficiency, cystic fibrosis on and off, some form of rare diseases like porphyria, all those things can come out actually under the PACES curriculum. So it's also important for us to know about all these conditions. Although it's not very common, but it can come out. Okay, so we will talk about the criteria later. But basically, you need to refer rheumato, not orthopedic. Okay,
Oh
because
yeah,
this is
Roman.
inflammatory joint pain,
Mm.
not mechanical.
Mm. Yeah, yeah.
After you refer to orthopedic, it's going to annoy the examiner. We are all medical person. We are not surgical, right? Yeah, you really need to mention. If you don't know how to mention about management, you can
Mm.
give a general picture. Just say that management will be multidisciplinary, focusing on patient education and counseling. I will involve a rheumatologist to get an expert opinion whether what spectrum of the articular migratory polyarthritis this patient belongs to, and may consider to start disease modifying therapy or immunosuppression. You can just mention at that because I give you the hint that if you think that this is something related to autoimmune, what is your direction of management? So this is
Mm.
another way that the examiner can try to score you, at least not to give you zero, but give you borderline. Okay.
Mm.
Okay. So for ASOD, the first line actually is the steroid. Second line is the MTX, just like something like RA, right? But the RA first line is actually MTX first. And the refractory cases need to consider biologics like IL-1 and also IL-6. And those other rare things which don't need to be discussed, something nice to know. And you mentioned about analgesia for joint pain is good. Okay. So I didn't manage to ask you a bit more question like concern, but I try to squeeze in the cancer part just to make sure that you cover up the possibility of lymphoma. Okay. But you mentioned something like unlikely, right? I remember. So to
Mm.
address
Yeah.
need to be a bit accurate as well. Try not to narrow down your differential diagnosis. And when you answer the concern, if you're not very sure, you just say that it is possible. However, we need to work out further. You don't have to turn around and then here and there is you say unlikely but still possible. Just mention that it's possible. However, at this point of time, I cannot ascertain. I need to do a further check. Okay. So the criteria of ASOD is called Yamaguchi, Yamaguchi criteria. It is important for you to know because it tends to be quite famous when it comes to PACES exam. Okay. So you mentioned about major and minor. How you remember? The way I remember is very easy. I remember a very fast plant a plant that grow very
Mm.
fast. Okay, so
Mm.
major like FAST, right? And then minor is about plant. So there's like total about 8 criteria. You just need to fulfill 5 and must include two of it must be from the major lah. So fever, arthralgia. So fever, this patient has fever, and then she
Yeah.
told 38 to 40 degree. Okay, definitely more than 1 week. You know that's fulfilled. Arthralgia also more than 2 weeks definitely, and the patient show you a rash. It's
Mm.
non-pruritic, non-tender, and also if you ask further in detail, she may tell you that actually the rash more noticeable when she having like high grade fever. Okay, and
Mm.
total white is something definitely you won't know because for the history and examination only. But let's see the minor, which is the PLANT. Phalangitis, limb adenopathy. She did tell you about phalangitis, right? Few months
Mm.
ago. And then limb adenopathy, there's palpable cervical lymph node. And the N and the T is the one that need lab workup as well, which is negative for rheumatoid factor and ANA. That's why this patient, when you order for autoimmune screening, you should also routinely screen for RA as well, rheumatoid factor and also ANA, other than the NTDS, CNDS, C3, C4, ENA. Okay, and transaminitis is something that need to mention as well because adult onset still tends to have some form of borderline transaminitis. Okay, so this is how we discuss about the ASOD lah. Okay, and anyone have any question? Do you have any question, Api?
Mm. So, can we keep this rheumatic fever in the DD, doctor?
Yeah, sure, sure. There's no
Mm.
doubt that this rheumatic fever can be in the differential diagnosis because of the migratory joint pain as well as a
Yeah.
prolonged fever. But the negative point, you should always justify yourself with the positive sign and symptom as well as the negative. The negative points for this would include there is no much of heart symptoms, and
Mm.
at the same time, there is also no the rash is not suggestive of erythema marginatum. Okay,
Mm.
and there's no murmur on auscultation in my finding.
Mm.
So that
Mm.
that points against this rheumatic fever. But rheumatic fever, yes, should include in your differential diagnosis. It's not wrong.
And how about reactive?
Reactive arthritis is also correct, can be.
Mm.
Uh, in order to know reactive arthritis, usually precipitated by infection, can be upper respiratory tract or can be GI. So you also need to ask in particular about any loose stool in the past as well. Reactive
Mm.
arthritis usually will have migratory polyarthritis, asymmetrical in distribution, inflammatory in
Yeah.
nature. But the negative points again to this is usually reactive arthritis will not have any rash unless you are suspecting the sexually transmitted disease causing this form of reactive arthritis. But usually they will not have any obvious rash. So you can say the negative point is actually there's no preceding symptom other than the flu, and there's also no unsafe intimate relationship or
Mm.
any evidence of infection over the private area. You can mention something
Yeah.
like that. Okay.
Okay.
So just before we go through the second scenario, I just want to give a very general approach to prolonged fever. This station essentially, if you ignore the joint pain, I mean the joint pain is actually helps you to narrow down a rheumatoid condition and the inflammatory kind of joint pain. So it gives you probably a clue that this fever is like maybe can be rheumato kind of case. So that's why you need to hit hard on the rheumatological part. Okay. But let's say this is
Yeah.
just a fever. Let's say this is just a case of fever, prolonged fever, went to multiple GP, given multiple course of antibiotic, not resolved. What is your differential diagnosis? So you need to write a few things in your mind. So this is how I will approach. Okay, I will divide into a few cluster. I will definitely think of infection, autoimmune, cancer, as well as some others cause, which is not uh not common, but something need to be included. So infectious, definitely infected endocarditis. I will start to write. I can write down initially the first common one first, then followed by like bacterial, parasitic, viral. Okay. So the common one I will definitely include is infected endocarditis, rheumatic fever, TB. If patient has some form of occupational exposure like farmer and those things, I will consider melanosis, brucellosis, all those things as well. Soil contact, right? And then I will write down bacteria, parasite, and viral slowly. Parasite, malaria can come on an exam, quite common, okay, especially cerebral malaria. And
Mm.
definitely parasite, you are also talking about toxo and OI. So you need to really screen through whether patient got any risk factor of getting HIV. Okay. Another thing is the bacteria, those very atypical, rare, perhaps you can good enough for you to screen any recent traveling and then and anything significant from the history. And viral, perhaps the important thing is the hepatitis. Make sure you screen for the GI symptom. This patient you didn't ask anything about jaundice, any tummy discomfort, any tummy distension at all. You need to screen, okay? And HIV you also ask. EBV, CMV is something possible, okay? EBV, things that can come on exam, for example, infectious mononucleosis, in which the rash appear after taken some penicillin-based kind of antibiotic, that will give a clue that this is a like a IM, infectious mononucleosis, okay? And there are other rarer patient, rarer virus, which to me, I don't think is very significant. So I will just focus on those that I actually put in bold, okay? So autoimmune, something that uh, important is the SLE. Myositis can come out in exams. Their symptom perhaps is only proximal myopathy with fever. Sometimes can have a bit of dermatomyositis picture if patient got very classic hair-tube rash, Gotham papules, all those things. And then RA is also something need to put in your back of the mind. Sarcoidosis as well, and ASOD. Okay, vasculitis also something is important. Like for example, Takayasu can be quite famous for exam. And the only way, perhaps, when you examine patient, if you feel for the pulse, you suspect it, you feel for the pulse, check for four limbs kind of pulse, you will feel that the pulse is actually very low or even absent or even unequal pulse. So that will give you a hint that this can be some form of Takayasu. Okay, and you also need to listen for carotid bruit. Let's say you're suspecting for Takayasu, as well as examine the abdomen, put your stethoscope to auscultate for any renal bruit to suggest renal artery stenosis. This is for Takayasu. EGPA, PENS, all those are a bit rare, but usually the presentation can usually will have a pulmonary renal kind of manifestation. So you expect some for hemoptysis or even some upper or lower respiratory tract symptom, as well as some abnormal kidney function as well as symptom. Okay, infection triggered like for this patient is also possible like post streptococcal arthritis or reactive arthritis. Okay, so neoplastic, you want to think about lymphoma or even myeloproliferative disease. And bear in mind that if it's in the elder age group, you want to think about non-hemato solid organ malignancy or even metastasis. Sometimes this kind of joint pain, fever can also be paraneoplastic manifestation. Okay, and the other thing, prolonged fever, you also need to think about a few things. For example, drugs induced. If patients are taking cocaine, like cocaine abuse, cocaine user, can actually have this prolonged fever intermittently, which precipitated by all this illegal drug use. And antibiotic fever is also something worth to mention as a differential if patient receive multiple antibiotic not resolved and the antibiotic already been given for quite some time, a long time duration. Okay, and I'm glad that you actually suspect hyperthyroidism because thyrotoxicosis can be very non-specific sometimes. The presentation, if you don't screen for GI symptom, you don't screen for menses, don't screen for a change in terms of hot or cold weather, you may miss the thyroid. So, and also neck swelling sometimes. So metabolic condition like prolonged fever, like thyrotoxicosis is something also need to mention. Okay. So with that, this is your general approach lah to prolonged fever, or what you call is PUO. You want to call it as prolonged fever, is fine. So is that anyone have any question? Up here, you're okay, right?
Yes, doctor.
Okay, so we'll proceed to the next candidate. Ting, are you there?
Benjamin.
Hey, hi. Okay.
Okay.
You're ready?
Yeah.
Okay, so we will start the timer. I give you 4 minutes starting now. Okay, time's up. Dr. Ting, this is the patient, Madam Saraswati. Please start.
Okay. Hello, hello. My name is Dr. Ting, one of the doctors in this acute medical unit. May I confirm, are you Madam Sarawati, 45 years old?
Yeah, I'm Saraswati.
Hello, Madam Sarawati. Nice to meet you.
Yeah.
Can Today we are here to discuss regarding your medical condition. Can you tell me more about your complaint?
Yeah, doctor, I noticed that I have been having a lot of water, drinking a lot of water for the past 3 months. I've also have passed a lot of urine.
Okay, all right. Okay. Do you ever measure that how many urine that you pass out?
I'm not sure, but I go to toilet about 10 to 11 times per day.
Okay, all right. Okay. Is there any bubbles in the urine?
No,
Okay. How's the urine color? Does the urine looks very diluted to you?
diluted as in clear. Yeah, it looks
Yeah,
quite
yeah.
clear.
Okay, all right. Okay. So how many amount of water that you need to drink in a day?
I drink about 3 liters of water every day.
I see. Okay. May I ask how is your body weight?
My body weight has been losing actually for the past 6 months. I think I lost about three kilos.
I see. Okay. Was it intentional or unintentional?
No, not intentional.
Okay, all right. Okay. Any fever?
No.
Okay, all right. Uh okay, I'm gonna ask a bit a few more questions. Okay. How about is there any do you find that you prefer cold weather or hot weather?
I think both are fine with me.
Okay, all right. Any dizziness?
No,
Okay, all right. Do you find that your shoe size is getting bigger and bigger?
no.
No. Okay, all right. How's your vision? Is there any blurring of vision?
No blurring of vision, but doctor, you can see my eyes is quite red, especially my left eye.
Okay, all right. Is there any pain in the left eye?
Yeah. When it occurs, it actually have pain.
Did you notice that this eye redness occur during the same time as you have this huge amount of urine?
Actually, for the past few months, I mean, for the past 3 months, initially my right eye started to have redness and pain, and it resolved by itself, and now the left eye comes.
I see. Okay. All right. Any fever?
No,
Okay. Do you have any joint pain?
joint pain, not really. No, there's no joint pain.
I see. Okay. Any rash over your body?
I'm not sure my nose is considered a rash or not because I noticed that my nose become like like a bit red, especially over the tip.
Oh, okay. Do you notice this nose red? Is it all the time that red, or is it occur certain time of the day?
It started about 2 months ago and it has been persistent like this.
I see. Okay. All right. Any runny nose?
No,
Okay. All right. Is there any shortness of breath?
no.
Okay. Okay. All right. Okay. Madam Sarawati, may I know that do you have any past medical condition that I should know of?
Uh, I actually have I actually have a bit of bone pain in the past, and my GP actually gave me some calcium supplementation, but I never done any bone scan before lah. But the doctor told me that I need to take calciums
I
with
see.
my bone.
Okay.
Yeah.
All right. Okay. So other than the bone pain, any other medical condition?
No, not that I'm aware.
Okay. Okay. All right. Do you have any tummy ache?
Tummy ache, not really.
Not really, yeah. Just a bit of question about your urination. Do you find that is there any stone in or sandy urine?
No,
No pain passing urine? Any pain passing urine?
no.
Okay. All right. Okay. So so you mentioned that you are taking some calcium tablet. Okay. Other than that, any other medication that you are currently taking or any supplement?
No.
Okay. No supplement, no traditional medication as well, right?
Mm.
Okay. Any may I know any medical condition that is running in the family?
Mm, I think my mom has diabetes. My father has high blood pressure.
Okay. All right. Okay. Okay. Any recent history of traveling?
No.
Okay. All right. Madam Sawati, how's your period?
My period is regular. I always have a regular flow. It occurs every month, and every time I have my period is about 5 to 7 days.
Okay. All right. Do you have any children? Sorry, are you married?
Yeah, yeah, I'm married.
Okay. Do you have any children?
Yeah, I have one kid.
One kid. All right. And when was your last pregnancy?
My child is already 3 years old, so it was like 3 years ago.
Oh, see. Okay. All right. Any issue with the delivery during the last previous pregnancy?
No, no,
No. Okay. Are you taking any oral contraceptive pill?
no,
Okay. All right. Any issue with the breastfeeding after you gave birth?
no.
No. Okay. All right. So, Madam Sawati, may I know, are you working?
Yeah, yeah. Actually I work as a cashier.
Cashier. Okay. I'm going to ask a bit of a question just to screen through. Do you have any headache?
No,
No headache. Any limb weakness? Do you notice your upper limb or your lower limb having weakness?
no,
No. Any racing, pacing of the heart?
no,
Any chest pain?
no.
Okay. All right. Okay. How's your bowel work? Do you have any loose stool or constipation?
I think I'm getting constipation in the recent 3 to 4 months.
I see. Okay. So how many times that you pass motion in a week? Like, do you
Mm, I think I only pass motion once per week.
okay? Do you feel like you have difficulty that you need to strain in order to pass motion?
Yeah, yeah.
I see. Okay. How is your stool color? Is there any change in stool color or any blood associated with it?
No, no. It was normal.
Normal. Okay. All right. Okay. Okay. So okay. May I know, do you smoke?
No,
Okay. Do you take alcohol?
no.
Okay. Madam Sarawati, I'm going to ask a bit of a sensitive question. Are you sexually active?
Yeah, yeah. I'm with my husband. We practice safe sex.
Okay, sorry to ask, is there any other sexual partner?
No, no. I'm loyal to my husband.
Okay, all right. Okay. Madam Sarawati, I would like to examine you.
Okay.
All right. So, I will start with the hand of the patient to look
Mm-hmm.
for any presence of any clubbing, any palmar erythema or any anemia pallor in this patient.
Looks normal. Everything.
Looks normal. Okay. Then I will check for the pulses of the patient. Is there any tachycardia with this patient or any arrhythmia noted in this patient?
No. Pulse volume
No.
is
Okay. All right. Then I will go for the BP, blood pressure. Is there any postural drop in the blood pressure as the patient having polyuria? I might expect the patient volume just to assess the volume status of the patient.
okay. Good. Volume status is actually good. Blood pressure. There's no postural drop.
Okay, all right. Then I will go to the face of the patient. I can see there is a eye redness over the left eye. So I will
Mm.
briefly check for the visual acuity of the left eye. Is there any issue with the visual acuity?
Visual acuity is actually full for both eyes.
Full. Okay, all right. Okay. So I will check I can see the rash over the nose as well. And I will look at the oral. Is there any oral ulcer?
No, there's no oral ulcer.
Okay, no oral ulcer. Okay. And then I will go for the neck to palpate. Is there any cervical lymph adenopathy?
Yeah, when you feel for the neck, there is a small palpable lymph node over the right cervical region. Measures about 2 cm, nodular,
Okay,
non-tender.
you know it's palpable. Okay, all right. I'll go for the chest region. I will auscultate the chest to look for any crepitation.
There's no crepitation.
Okay, and then I'll check the heart. Is there any murmur? Uh,
Mm, S1, S2 is hurt. You cannot appreciate any murmur.
yeah, okay. And then I will check the axilla to look for any other lymphadenopathy, inguinal lymphadenopathy.
Examiner say you can skip.
Okay, I will check the abdomen to look for any hepatosplenomegaly.
Okay, as you lie the patient flat and you sit down. When
Hmm.
you slowly, you notice that there is a palpable lever about 2 finger breadth from below the costal margin.
Oh, liver is palpable. Okay, spin,
Crop space is down.
top space is down. Okay. All right, and then I will look at the lower limb to look for any pedal edema and check for any rash over the lower limb.
There's no rash, no pededema.
No rash, no pedal edema. Okay, all right. So, okay. Madam Sarwasti, do you have any concern?
Yeah, doctor. Why am I feeling thirsty all the time?
Okay, sorry, just to ask a bit of extra question for you. Do you, okay, you feel extra thirsty, do you have any, sorry, just now you mentioned that you have weight loss, right?
Mm,
Oh, okay. All right. So, okay. So, for your condition, I think, you are having a condition that is called, sarcoidosis, which is, don't bother about the medical term. I think it's a condition related to the immune system, misdirected towards the organs in your body, and it has caused a lot of inflammation over multiple organs in your body. So, it can also cause high calcium in your body. So I believe that your symptoms are actually related to the high calcium, which can cause you to feel very thirsty, and also you're passing a huge amount of urine.
oh, okay. Doctor, is,
Okay.
is condition curable?
Okay, this condition is actually controllable. We can manage. This condition will definitely need a long-term follow-up. After that, we will need to monitor your symptoms. Most of the patient will respond
Two
fairly
minutes
well
left.
with medication. Madam Sarawati, do you drive?
Yeah, yeah, I'm driving.
Okay, so because of your eye condition, I will need to stop you from driving. I will need to inform our driving agency, driving DVLA, and to decide further whether you can drive in the future or not until your vision is okay.
Doctor,
Do
but
you?
but have any
Yep.
blurry of vision at all, doctor?
Yeah, we will need to get the eye doctor to check your eye properly, so that we need to ensure that this does not happen again and you will not impact your vision and so that you will not leave permanent damage for you. Is that okay?
Okay, doctor. Doctor, is this some form of cancer?
Uh, at the moment, cancer is very down my list because cancer can also cause high calcium in the body. But however, cancer is very down my list. We will definitely work you out, and we will check for every possibility of cancer in your condition, and we'll update you as soon as we get the result. Is that okay with you?
Yeah, yeah. Doctor, is this condition actually related to my nose that appear red?
Uh, yeah, okay. So this condition can also cause some redness or skin rash over your body. If we treat your condition, the skin rash should improve.
Oh,
Okay.
okay.
Don't worry. We'll also get the skin doctor to have a look at your nose just to make sure we are not missing anything.
Okay, doctor, last question. Will I suffer from any complication from the condition you mentioned?
Okay. So complication, yeah, certain patient they will have problems with the lung. Okay. If the problem is not managed properly, they will develop long-term lesion in the lung that can cause them to have shortness of breath. And certain patient, if the
Time's up.
calcium level is not, okay,
Okay, time's up. Dr.
yeah.
Ting, would you mind to go through the diagnosis and the provisional diagnosis for this patient?
Okay, my diagnosis in this patient is the provisional is sarcoidosis in this patient. Evidenced by the patient having hypercalcemia symptoms, as well as the presence of uveitis, and also the rash of the nose, I believe, is lupus erythematosus.
Okay.
And I will my other differential is medication cause of hypercalcemia because the patient is also taking calcium tablet, so it might be due to the overdose of the calcium tablet. My third differential can be due to diabetes insipidus or diabetes mellitus. So for the diabetes insipidus, um, unfortunately, I did not find any sign suggestive of a pituitary issue that caused diabetes insipidus or cranial DI in this patient. However, I cannot rule out nephrogenic DI in this case.
Mm.
Diabetes mellitus is also one of my investigation possible diagnosis. The thing that is against it is that the patient having weight loss. Although diabetes mellitus also patient can have weight loss, but it will be down my list. Yeah.
Any other differential diagnosis in terms of hypercalcemia?
Yeah. The malignancy, given the patient age, also a middle age, we need to look for any chronic infection like tuberculosis
Mm,
or malignancy like lymphoma, especially the patient having lymph node palpable in this case.
sure. How will you investigate this patient?
First, I would like to do a blood urea and creatinine as well as a serum electrolyte levels to look for any hypercalcemia in this patient, as well as look for any complication of the hypercalcemia that might cause renal impairment from the renal profile. Secondly, I would like to do a HbA1c just to rule out diabetes mellitus in this patient. As uh, I would also like to do a pituitary hormonal profile, including TSS, HTH, FSH, LH, IGF, as well as prolactin, just to rule out is there any pituitary cause of polydipsia in this patient. The lymph node, I would like to do a lymph node biopsy in this patient to look for any granuloma in the lymph node, as well as I would like to do a chest X-ray to look for any infiltration of the chest that might be suggestive of in terms of sarcoidosis. For the nose, I will consider to do a skin biopsy, and yeah, and for the I will do a serum ACE level also to check for any if raised is suggestive of a sarcoidosis.
How do you differentiate the causes of hypercalcemia based on the investigation?
So hypercalcemia we can divide into is whether is it a PTH dependent or independent. Oh yeah, I will also check the PTH in this patient, IPTH in this patient. So whether is it IPTH related, dependent or non-dependent, this patient.
Other than performing X-ray, is there any investigation you want to order if you are suspecting sarcoidosis?
We can do a HRCT or CT thorax to look for any lymph nodes in the lung region. We can also, if there is, we can do a bronchoscopy and perform a transbronchial biopsy to get the HPE read of this patient.
Okay, all right. Then how will you manage this patient?
So for the hypercalcemia, I will start the patient on hyperhydration up to 6 to 8 liters a day and monitor the urine output closely. And we will check the calcium level, monitor the calcium level closely. If hydration is not effective in this patient, we can try bisphosphonate in this patient. For the case of the sarcoidosis, because of the higher presence of hypercalcemia, we could start steroid for this patient. We will start steroid for this patient to control the inflammation.
So what would be your indication to start steroid in a patient with sarcoidosis? Do you start in all
So
patients?
hypercalcemia is an indication to start steroid.
Mhm.
Other than that, if there is a multi-organ involvement like a lung, heart, eyes involved, or neurosarcoid CNS involvement, that will also be an indication to start steroid.
Okay,
Yeah.
all right. Time stop. Okay,
Okay.
so we stop the timer. So how do you think about your performance?
I forgot to ask about the mental, possible primary polydipsia in this patient. And also, I think I forgot to ask the patient to stop the calcium pill during the concern
Yes.
session. Yeah.
Yeah. Another
Yeah.
thing is that you are a bit disorganized in your history in beginning and until towards the end. When you ask about the concern, you say chop chop chop. Sorry, I want to ask you again something. When the patient
Yeah.
asks about twisty, like you cannot disturb the flow, meaning to say that you need to be very sure, you need to be very smooth. So your systemic review ideally should actually comes after the HOPI lah. Oh? But
Okay.
because you see that your thoughts are everywhere and you are a bit panicked in a way, that's why you're a bit disorganized, you're a bit jumpy lah. But
Yeah.
okay, but when you get this scenario assessing test, you need to really elicit whether this is like a DI or this is like a hypercalcemia lah. But because I think first few questions did not able to differentiate, and that's why it makes you very disorganized in a way
Yeah.
because you should both at the same time.
Yeah. Actually, initially, I didn't think about the hypercalcemia until the past medical history mentioned about the bone pain and calcium. That suddenly triggered me to ask about the
Yeah,
hypercalcemia.
yeah. It's quite
Yeah.
obvious to everyone, I feel.
Yeah.
And I would expect you to really screen for other than the bone, also screen for GI. If you didn't ask about outer bowel habit, I will definitely not going to mention. So constipation something is important, huh? It's very important. And to actually quantify the polyuria, although patient cannot quantify, right? You can actually ask how frequent he or she needs to wake up to go to toilet at night when she sleep. So that can actually tell you how significant the polyuria lah. Because if it's like a physiological kind of polyuria, usually we will not until develop nocturia more than 3 times. Usually body can actually last unless patient with BPH lah. But usually patient can the body actually can tolerate and usually will not develop like very obvious polyuria. But if you ask this patient, the patient will say difficult to sleep at night, and you ask why, don't know, I just cannot sleep. That can also be one of the symptoms of hypercalcemia already, insomnia. Huh? Another thing is
Yeah.
actually she may tell you that I have to go to toilet very often to pass urine to pee. So that it can also tell you already this cannot be just like DI. This is something more. So that's why it's important. And if you know that this patient is like very hypercalcemia, you won't go in detail to screen for pituitary lah. But this patient, I won't against you if you want to order the pituitary hormone panel. Any other justification other than because of the symptom to suspect DI in regards to sarcoidosis?
Yeah, it's because sarcoidosis can also cause infiltration of the pituitary gland, so we need to screen for it.
Yep. So neurosarcoidosis is also one of the possibility. Okay, so I think you are okay. Most of the you got most of the point. I suppose no problem. But just the examination part, yeah, I will go through in the next slide. So if I'm going to score you, I think you can get almost full marks. Yeah, can get almost full marks. The only thing perhaps in terms of jargon is instead of asking patient, do you have any weakness over your upper limb and lower limb? You should actually ask, do you have any weakness over your arms and leg, arms or leg?
Oh,
I try not to
okay.
use a term that medically we use, lah. Okay. Other than that, I think you didn't use much jargon. I think you can score most of the full marks, lah. So for history taking, for just to go to the scenario, lah, you got most of the history, but I cannot really find from the history that you try to exclude TB and the sick contact. You did ask about traveling, but you didn't really kind of like screen for TB, asking for any cough, any coughing or blood, any
Yeah, I didn't. Yeah.
at night. Yeah. And lymphoma is something also you need to really exclude as well. Any tummy discomfort, any tummy pain, okay, and any lumps and bumps over the body. Okay. If you ask me, I will already tell you that I think I got some lump over my neck, right side. Okay. And if you think this is a sarcoidosis, I know the cutaneous symptom. I mean, the cutaneous sign is very obvious. Basically, what she has is actually uveitis because it's painful, right? Yeah, and you need to check for seventh nerve and also parotid gland swelling if you're suspecting sarcoidosis. Same goes to rheumatoid arthritis patient. You also need to check for parotid gland to look for amyloidosis. So for sarcoidosis, you also need to check for the parotid swelling and also look at the patient. If you got time, you should also check for the seventh nerve because we know that sarcoidosis can affect lower motor neuron seventh nerve palsy. Okay, so this is something extra that you need to screen through. But if you didn't screen, it's fine also. Okay, and then lungs capitation is good because you're suspecting that. And yeah, you'll cover pretty much of it. And the investigation for hypercalcemia, you must mention IPTH. You cannot ignore it because that's the reason, that's the indicator that you can differentiate between whether it's a parathyroid problem or secondary problem, right? And when you mention about hypercalcemia workup, you should mention all this in a whole. You should mention that order calcium, albumin to look for corrected calcium, IPTH, bone profile, vitamin D, bone mineral density scan, renal profile, urine FVME, as well as the other secondary causes. You didn't mention anything about TB workup for this patient.
Yeah, I didn't. Yeah.
And then you mentioned about X-ray, serum ACE, lung function, not really, but HRCT you mentioned. And bear in mind that if this is a scenario of sarcoidosis, right, it is a must that we need to do a baseline ECG. Okay, the reason is it's quite common patient with sarcoidosis can have some form of cardiac sarcoidosis in the early disease, in which they can have some arrhythmia, they can have some prolonged PR interval to suggest first degree heart block, and therefore it's also require echo if it's present. So like baseline ECG is something is a must to mention for all sarcoidosis patient. And we can even have one scenario like counsel on ICD with a patient with with a patient of cardiac sarcoidosis that come up before. So you can see that sarcoidosis and the heart is something we need to mention. And lymph node biopsy, you should also mention that you want to biopsy lymph node, and you should also mention what you want to look for. You want to look for what kind of granuloma, non-cassating or cassating?
Non-cassating granuloma.
Yeah, non-cassating granuloma. So that will point to sarcoidosis instead of TB. Okay, so if you're suspecting like infective issue, you also need to mention about infective screening. But generally, most of the thing you mentioned, and generally we start steroid in those with so-called severe pulmonary involvement, meaning to say that the sarcoidosis of the lung that progresses into a very advanced stage, but it is still like OP or UIP subtype, inflammatory subtype instead of fibrotic subtype, then yes, you will start steroid for pulmonary. But generally, we start steroid for extra pulmonary manifestation of sarcoidosis, which include the hypercalcemia, uveitis, lung, nerve, cardiovascular as well as CNS manifestation. Okay, so I think that pretty much conclude the case. Any question you want to ask me?
I think that's all. Yeah, I think it's very clear after you listed out all the investigation. Yeah.
So I know that you know that you got a diagnosis and you want to really score it, but try not to be too panicked. You just need to go by systems a bit more systematic. So you, in terms of hypercalcemia, what you want to do, and then in terms of investigating what is the test, and then consider blood tests, and then point of care, and then imaging, and then histological. That's why lymph node. So you just need to be a bit more systematic. Then the examiner will feel like, okay, this one no problem. Okay, very smooth. Okay.
Okay.
So there's some extrapulmonary sarcoidosis that we need to know a bit, but I don't think if it come out, I don't think examiner will remember also. Sometimes examiner also, they are not chest physician, they are not someone that deal with sarcoidosis that common. But Malaysia, bear in mind that Malaysia, the reason why I give an Indian name in the female, there is an implication. The reason why I set this scenario, because in Malaysia, sarcoidosis is not that rare. It is quite common, especially in Indian population and female reproductive age group. We're talking about like 20 to 40 or 50 years old range. So this kind of patient with hypercalcemia, with a bit of lung, sometimes may not have any lung symptom. So you really need to suspect whether this can be sarcoidosis, especially you feel that there is some form of limb adenopathy there. Okay. So Malaysia is not common, but it can happen. Can also come out in exam as well. So Lofgren syndrome is something you need to know. It's basically rheumato as well as the dermato kind of manifestation. You can have fever, adenopathy, erythema nodoso as well as arthropathy. So this arthropathy is periarticular, meaning to say it does not affect the joint, but it affect surrounding the joint. So that's why what we call as periarticular arthropathy. Commonly it actually affects both ankles. Sometimes can involve knee, wrist, and elbow as well. Okay. So another spectrum is actually uveal pyrotic fever, in which it affects the face mainly. It affects the eye as well as the facial nerve because of pyrotic gland enlargement. So this is a Herford syndrome, which is also quite rare. But this is something you need to know because when you talk about extrapulmonary sarcoidosis, there's a few spectrum, few association. One is a Rofren, tend to be more so-called commonly asked. Second is the uveal pyrotic fever, and the third one that the patient has is actually lupus pernio. Okay. Subsequent, the remaining one is the cardiac and the neuro and the cardio central nervous system manifestation, neuro kind of manifestation. Okay, so the just to recap again about hypercalcemia, because if you suspect hypercalcemia, you need to ask about everything about hypercalcemia. So for like we mentioned in the previous session, we also mentioned something about hypercalcemia workup before. Symptom is quite simple. You just need to go by system. So you ask about the brain, including the psychiatry and the mental. That's why you ask about confusion, dizziness, polyuria polydipsia symptom. And then how about the mood? For this patient, you didn't ask about the mood, okay, to suggest hypercalcemia. And then second is the heart. Heart is mainly the arrhythmia and palpitation, nothing much. And then subsequently followed by your bone as well as the bowel. Okay, so bone and bowel, you are talking about bone pain. Sometimes can have fracture in the elderly, pathological fracture, young fracture, and then bowel is something you need to ask as well, constipation. And bear in mind that always screen for any lactic ulcer disease and pancreatitis in a patient with hypercalcemia, because this can be one of the complications of hypercalcemia as well, other than constipation. Okay, and then the DU part, which is the urine, nothing much. This is just to screen for the kidney, just to screen for any kidney stone, and then any kidney stone in the past, any kidney stone or any bleeding in the urine, blood in the urine. So differential diagnosis, you should always differentiate between PTH dependent and non-PTH dependent. PTH dependent elevated PTH can be primary, secondary, or tertiary. So primary can come out as a FHH or parathyroid hyperplasia. I think we discussed the parathyroid hyperplasia as in association with MEN1 or MEN2A during the last scenario, last session in Campfire. So we will go through. And bear in mind that we cannot really confirm the diagnosis until we correct the vitamin D. Let's say patient is vitamin D deficient. So in every hypercalcemia patient, actually part of the workout is also include vitamin D level. We want to make sure that vitamin D is actually adequate. Okay, because vitamin D deficiency alone can cause hypercalcemia. Okay, and secondary tertiary is mainly the kidney problem CKD MBD or the end stage. Non-PTH dependent, you expect the IPTH level to be normal or even low. Okay, usually it's low but it can be normal. So the problem with this non-PTH dependent hypercalcemia, the commonest is actually humoral hypercalcemia of malignancy. Okay, so you must really screen for, not for this patient because she's still like middle age, but for patient like a bit elderly, you want to suspect about bone metastasis. Okay, patient can have prostate cancer with a bone mets, bone pain, and then come here because of excessive thirst, for example. And then hypercalcemia, famous cancer, another two famous cancer is actually lymphoma and myeloma. So you may want to screen for CRAB, okay, to suggest myeloma. And then the third one only in which one of the discussion for today is actually the sarcoidosis, okay, other than TB. TB also can have borderline hypercalcemia, but usually it's not very high. And drugs, like we mentioned, so vitamin D deficiency can cause hypercalcemia. Vitamin D excessive use and also calcium supplement can also cause hypercalcemia as well. And some other drugs like lithium, uh, some other rare drugs can also cause hypercalcemia. And endocrine causes also important. Want to screen for thyroid, adrenal, as well as acromegaly. And yeah, I think being screened for acromegaly is because he suspects some pituitary. Incidentally, he screened for that. But sometimes hypercalcemia causes not common. Acromegaly can associate with hypercalcemia, but it's more common with patients with hyperthyroid and adrenal insufficiency. Feel is something is always mentioned there, but we hardly see anyone with feel that have hypercalcemia. And immobilization or fracture is something we don't want to mention until we are so desperate, because most of the time it's not the cause. So our focus is mainly the first four, perhaps I would say. First four is the most important thing we need to exclude if you're thinking about secondary cause of hypercalcemia. Okay, with that, anyone else have any question? If not, we will go to the third candidate. Today has been quite silent. I think everyone ponchak already, those that go for mock. So let's go
Thank
to
you,
the
Jimmy.
thanks. So let's go to Chiu. Chiu, are you there?
I am here.
Okay, sure. So are you ready for the case?
Yes.
Okay, so I will start the timer. I give you 4 minutes. Your time will start now. Okay, time's up. Dr. Chiu, this is the patient, Mr. Evin. We start.
Hi, good evening. Am I speaking to Mr. Evin, 42 years old?
Yeah, I'm Evin here.
Hi, I'm Dr. Chiu. I'm the doctor in the acute medical unit today. Today I'm going to ask you a question and also examine you. Is that okay for you?
Yeah, sure.
So I understand that you are having this problem with your skin. Can you tell me more?
Yeah, doctor, you can see this is my leg. I've been having this redness over my both of my legs for for almost 4 months already, doctor.
Okay. So can I ask, did it happen gradually?
Mm, I don't really recall when does it happen gradually or not, but I realized that he has been comes and go for the past 4 months.
All right. Is it getting worse?
Mm, I don't think it get worse, but it has been persistent. And the problem is actually is painful. That's why every time it occur, I feel very painful.
Okay. Is there anything that make it worse?
Not that I know of, doctor. Usually, what I try to do is I will take some uh pain medication like paracetamol, and then I hope that it can reduce. But it doesn't really helps. I mean, the rash will go off by itself.
Okay. So you mean to say that the rash will disappear and reappear again?
Yeah.
Okay. Um, so can I ask, the rash is only on your leg or any other part of your body?
Yeah, I mean for the rash is only over my leg.
Okay. Do you have any history of prolonged coughing?
No,
Do you have any fever?
fever. Not really.
Okay. Do you have any history of coughing out blood?
No.
Have you noticed this happen after you taking some drugs or medication?
Um, I don't know because doctor previously I also take some this Celecoxib and Voltaren because I also got multiple joint pain in the past. So I don't know whether this medication also possible can cause this.
Okay. Just now you mentioned you have multiple joint pain. So can you tell me more of the joint pain?
Yeah, doctor. I have multiple joint pain for almost 1 year already. So I went to few GPs and they told me that I this can be due to gout. So they has tried to start me on medication called allopurinol. But after I take the medication, I stop it myself because I don't think it's helpful. I also taking some cortisone in the past, which actually helps with the joint pain. But generally, this kind of pain has been on and off as well.
All right. Can I ask, where is the place of your joint pain?
Yeah,
Which joint involved?
multiple joint as well. It can occur over my wrists, my fingers, also my ankles and also my toes. My knee also sometimes is having pain.
All right. Is there any swelling of your the part of the joint pain?
No swelling.
Okay. Um. Okay. Sure. Do you have any chest pain?
No,
Any difficult breathing?
no.
Any problem with your blood passing out like loose motion?
Loose motion, no, not really.
Any blood in the motion?
No,
Any tummy pain?
no tummy pain.
Is there any history of sore throat?
No.
Right. Do you have any problem? Like, do you feel always feel tired?
Always feel tired. I don't know because if I'm having joint pain and this pain over this my shin area, then I will feel tired because of the pain.
Right. Okay. So, is there any like do you can you tolerate cold or hot weather?
No, it's the same for me.
Okay, how is your appetite?
My appetite is I think is fair, but when I'm having pain, it tends to get reduced.
Okay. Uh, do you have any weight change? Any change in your weight?
Not really.
Okay. Um, do you have any dizziness from standing from sitting position?
No.
So the can I ask about the joint pain again? So you mentioned to me you have multiple joint pain. Was it worse like in the morning that and you're having stiffness of the joint?
Yeah, I mean, when I have pain, I will have a lot of stiffness in the morning. Lah. Sometimes it lasted more than 1 hour.
Okay, is it worse at night when you're sleeping?
If I rest, the pain is still there, but if I do activities, it tend to get lesser.
Okay. Do you have any eye pain or eye redness?
Yeah, sometimes I feel like I have a bit of redness and pain over my eyes.
Okay, do you have any like scaly rash over your body?
No, no, no. There's no rash other than my shin.
Okay, alright. Do you have any past medical condition that I should be aware of?
Yeah, doctor. I about 2 years ago, I was told to have blood clots in my left leg, and I went to GP and it was swollen at the time. And then the GP gave me about 3 months of the medication called Rivaroxaban. So after 3 months of the medication, I received back the GP. The GP told me you can off the medication because cannot find any obvious cause for this lah.
Uh, do you have any ulcer in your sorry, do you have any soreness in your mouth?
Not really.
Okay, any soreness in your private part?
Oh yeah, now that you mention about it, I sometimes I notice that my private area actually tends to sore easily as well, and it takes some time to heal. I need to apply some ointment and then some antibiotics for that to heal. It was
All right.
almost about 1 year already.
Okay. So beside the blood clot that happened before any medical illness that you are having,
No,
any past surgical history?
no,
Okay, just now you mentioned to me you're taking celecoxib and Voltaren. Any other medication over the counter you're taking?
no,
Okay, are you allergic to any medication?
no, not that I know
Any
of.
fam Okay, any family member having this history of blood clot?
No.
Uh, any disease running in the family?
My mom have diabetes. Other than that, the rest is quite well. No other issue.
Sir, I'm going to ask you a bit sensitive question. I hope you don't mind. Are you married?
Yeah, yeah, I'm married.
Do you have children?
No, I don't have children at the moment.
Okay. So, do you have any other sexual partner other than your wife? I mean, other casual
No, no,
partner?
I'm loyal to my wife. Why you ask that, doctor?
I'm sorry to ask about this, but this will help me to explore other condition. Okay.
Okay.
Do you smoke, sir?
No.
Okay. Do you drink alcohol?
Yeah, occasionally I'm doing for social gatherings.
Okay. May I know what do you do for your living?
I actually work as a mechanic, repairing cars most of the time, and this pain and also the rash over my joint has been bothering me a lot. So it actually affects my work.
Okay, I'm so sorry to hear about that. I will try my best to explore more on your condition and hope at the end I will give you I will get to the bottom of it.
Okay.
So I'm sorry to ask another sensitive question. Do you take any party drugs?
No, no.
Okay. Do you drive?
Yeah, I drive.
Okay. Is there any history of traveling before the onset of this rash?
No.
Do you can I ask three more questions before I examine you? Do you have any headache,
No.
any weakness over your hands or feet?
No.
Okay. Okay. Sir, may I examine you now?
Yeah, yeah. Please.
Okay. Now I'll start to examine the eyes. Is there any redness?
Now no redness. The eye appears normal.
Okay. Now I would like to check the neck. Is there any lymphadenopathy?
No lymphadenopathy.
I would like to check the oral cavity. Is there any oral ulcer?
No oral ulcer.
Any rash over the face?
No rash.
I'll proceed to the abdomen. Is there any splenomegaly?
Abdomen is soft. No palpable organomegaly.
I would like to take the consent whether I can check the genitalia.
Examiner say you can skip. Patient have no active ulcer at the moment.
Okay. I would like to look at the. Is there any evidence of synovitis over the hands?
No. The hand appears normal.
Any synovitis over the elbow?
The elbow range of motion is normal, not inflamed.
I would like to auscultate the lungs. Is there any crepitation, fine crepitation?
When you auscultate the lung, the breath sound is equal both sides, from upper zone to lower zone. There is no crepitation.
And I would like to look at the rash and examine the rash. Is the rash painful on palpation?
You mean the rash over the shin?
Over the shin, yes.
Okay, the rash over the shin is actually painful, especially those with red appearance.
Okay. Is there any is the both cuff equal in size?
Yes, it's equal in size.
Is there any
2 minutes
ulceration
left.
over? Is there any ulceration over the legs?
No observation. You can see just like this.
Is the rash blanchable?
Non-branchable.
Is the rash elevated?
It appears like this photo.
Okay. So may I know, do you have any concern?
Yeah, doctor. What am I having, doctor?
So I believe you are having a condition known as Behçet disease. Don't bother about the medical term. It is a condition that is attacking your immune system, that causing you to have this problem with rash and joint pain and also soreness in your private parts. Yeah.
Okay. Is this cancer, doctor?
No, it's not cancer.
Okay. Is it curable?
Unfortunately, this condition is not curable, but it is controllable, and we have medication to control your symptoms.
Doctor, my previous GP say I may have gout. Is this gout instead of having this Behçet's disease?
No, your condition is not due to gout.
Okay. Okay.
Yeah.
And do I need to be admitted?
I don't think you can be managed as an outpatient basis. We'll run some blood tests on you, and we will follow up you in our clinic. So you don't need to be admitted.
Okay. Is this a family disease? Because I'm planning to have a kid soon.
Okay. There's no direct inherited pattern for this disease, but if someone have the disease, the one will have a more chance to have it.
Okay, Dr. Chiu, can you run through your list of differential and your provisional diagnosis for this patient?
Okay, my top differential diagnosis for this is Behcet disease. Sorry, erythema nodosum secondary to Behcet disease.
Mm-hmm. What is the
Other
evidence?
as evidenced by the erythema nodosum and history of thrombosis, TVT,
Mm-hmm.
with uh, ulceration over the genitalia,
How about the eyes?
and also possible anterior uveitis.
Okay, and any differential diagnosis?
Other differential that I would consider include sarcoidosis, inflammatory bowel disease, post-infection such as post-streptococcal infection,
Mm-hmm.
or tuberculosis.
Okay, any other differential?
I will also consider drug-induced for this
Mm.
patient as the patient is also taking NSAID.
Okay, good. How will you investigate this patient?
So I will start with the laboratory investigation, including full blood count to look for anemia of chronic illness, and check. I would check for. Uh, I would check for autoimmune screening, such as ANA, and I'm sorry, I forgot the HLA test for this patient.
Wait,
And
you want to do HLA test?
no, I mean the the serology test for for Behcet disease.
What kind of serology test?
Uh, Sorry, I'm not sure.
It's okay. Any investigation you want to order?
Okay. I also order ASOT,
Mm-hmm.
and ESR to look for. I would expect the ESR to be elevated, and CRP as well.
Okay, okay.
Um,
Oh,
I also order chest X-ray to exclude tuberculosis,
okay.
and
How
also
about
to look for lymphadenopathy in the X-ray.
hmm? How about IBD then? You're suspecting some form of IBD. How would you investigate?
Okay, I will also arrange. mm, I will also arrange for colonoscopy.
You mean like now when patient have no symptom? Okay, never mind. How with regards to Behcet's disease, how will you manage this patient?
So I will manage it in a multidisciplinary team, which I will include rheumatologists, and I would focus on the patient education and counseling, and to avoid in educating to avoid uh, the drugs that he's taking, and to also referring to the occupational health physician, to help it with his modification of this work and home environment to maintain the independence. And I will consult a rheumatologist for the suitable option for the analgesia for the joint pain. And I will also
Mm,
address
what kind
the.
what kind of analgesia you will consider for this patient?
I will consider probably paracetamol
Mm-hmm. Anything else?
and co- uh, disease modifying agent.
Include what is the example?
example can be methotrexate.
Okay. Okay, time's up.
Yeah.
Okay. Chiu, how do you think about your performance for this scenario?
Um, I think I didn't manage to investigate well for this diagnosis.
But you managed to get a diagnosis, right? I think you're good. Oh, your history is good. You managed to get the diagnosis of Behçet's disease, but probably that only hits you when I mentioned about the DVT part, right?
Yeah.
Mm. So, spot diagnosis, when you saw the patient, you already know this is erythema nodosum. I can see that you screening for the causes, like including the IBD, the post-streptococcal flu symptom, oh, and also some rheumatological symptom as well as malignancy. But you didn't put this Behçet's disease in your differential. That's why you didn't ask until the clue is actually the DVT lah. Oh? And have you read about Behçet's disease before?
Yeah, but not in detail.
So Behçet's disease is another favorite PACES kind of scenario that we need to know lah. Oh? So you must know what is the diagnostic criteria. How do you diagnose Behçet's disease? Do you know?
I don't know.
It's okay. So actually, there's no serology to diagnose Behçet's disease one, okay? Behçet's disease is an autoimmune disease, and the only so-called test that you can do is called pathogy test, but that itself is also like not very, very specific for Behçet's disease. But you can mention that lah, if that's, I mean, that's the only test you can offer. But the main issue when you are out of, I can see that when back under the investigation part, you're actually a bit stuck because you don't know what to offer, right? Because you are
Yes.
thinking all Behçet's disease. But bear in mind that in basis, it's not just about getting the diagnosis, it's also about excluding the differential diagnosis. So just mention everything that you already asked is suspected. So you just tell everything, like for example, ASOT, you should mention it, autoimmune screening, and then for IBD, you can also send the stool for any or carbon test. If positive, then possible can arrange for colonal. Okay, and then you also can talk about inflammatory marker in which you did, and what else? If you're worried, you can also send for a full blood picture. For this patient, do you consider skin biopsy?
No.
Why?
Because I think it's clear it's a erythema nodosum.
So we don't biopsy erythema nodosum. The principle is we only biopsy if we think it's something else, then we need to biopsy. Erythema nodosum is essentially a clinical kind of diagnosis, a spot diagnosis. So we even if you diagnose, even if you do a skin biopsy on the erythema nodosum, you will not find anything. Okay, so it's not helpful. So the idea is just clinical diagnosis. Okay, so we will go through a bit. I think if we're going to mark you, communication is okay, examination is also very good. But I think you are a bit slow in your history taking because you use about 10 minutes, 10 minutes to actually complete your history before you examine patient. So again, that is still a bit too lengthy. You need to speed up and you also need to be a bit more structured. I can see you're almost there already. The way you ask history is quite, I can see your direction of thinking, but you need to be a bit more fluent at the same time, a bit more structured lah, because you're almost there. If you ask a bit faster, then you can have more time to examine the patient. And another thing about your examination, for this patient, right, always go to the chief complaint first. You don't have to examine the eye, the joint, the lungs, the abdomen. Only you go to the leg. If let's say you only got 1 minute, which one you want to examine first?
The leg.
Correct, the leg. So don't examine the thing that is not going to give you. I mean, they may have some sign, for example, lymph node, this and that, but they are not the main thing. You need to settle the main dish first, which is the leg, because they're going to calibrate. Imagine if you are the examiner with this kind of rash over the shin, definitely the calibration for the physical examination will be under the leg examination, okay, including checking for the calf tenderness because of so-called DVT before. So you must really examine the leg instead of examine the rest first. Okay. After you examine the leg, and then you only go for joint examination, check for simple any synovitis, any tophi to suggest gout, any rheumatoid nodules, and then any eye to suggest any eye lesion or oral ulcer or and then offer for some check for private area lah. All these thing is okay, but you need to prioritize your examination to get the maximal score. Okay, clinical judgment is unfortunately I need to give you more time for the clinical judgment. The rest actually you get full marks. Okay, it's because probably it's not very fair as well because you're not very familiar with Behçet's disease. Same goes to everyone. Everyone that go for PACES should know about Behçet's disease because it can come out in a scenario of thrombotic scenario like VTE or DVT or even PE, the scenario of PE, young PE. So it can come out with the diagnosis of Behçet's disease. It can also come out like this as a somehow erythema nodosum, skin lesion. Then you then you know that this is an autoimmune Behçet's disease. Okay, so when you ask about history, I think you got most of the thing. Yeah, most of the thing is you got it. In terms of the joint examination as well as the sheet examination, right? You also need to mention that it's a tender, subcutaneous, symmetrical, non-ulcerative, and it's bruise-like appearance if the examiner asks. And then you have to check for calf tenderness, check for eye and a joint, palpate the lymph node. And for Behçet's disease, remember, because you ask patient driving or not, yes, then you stop from there. You should ask patient saying that, okay, but let's say you have any blurred vision, I would advise not to drive until we saw what is the cause. Okay, so you cannot stop from there. You know that the patient have any eye symptom already, like redness, painful, or suspecting uveitis already. You should tell the patient that if you have any pain, you should not drive. Okay, but let's say patient have active uveitis, then you should advise against driving immediately. In which you should inform the driving authority and you should stop driving. I will advise you to stop driving until your disease get controlled. Okay, so you must address that part. Okay, you cannot just leave it blank like that. And then for this, in particular for Behçet's, you would actually offer to do a fundoscope to look for vasculitis of retina. So Behçet's disease is actually a form of variable vessel vasculitis. It does not affect like a large or medium or small. It affect any of the vessel. So that's why it's a form of vasculitis. Vasculitis is difficult because it tends to have a lot of symptoms, multi-systemic involvement. And this patient, you got a diagnosis of Behçet's disease. Good, very good. I will expect this scenario, I will calibrate this scenario as a scenario with a quite difficult scenario to me. But I think you are very good. You can get the diagnosis. And you have to offer a differential diagnosis. It's also good. But only after I prompt you, only you mentioned about the drug induced, right? Yeah, in which you also know that the NSAID can also cause erythema nodosum. This is also something you need to keep in the back of the mind. And then when you talk about investigation, I think it's fine. And then management, basically, like I mentioned, you must counsel MDT. If you don't know anything, also just mention MDT, patient education counseling, give you a few seconds to think, and then referral to which particular specialty that can help you. And then anything else in terms of lifestyle, anything non-pharmaco that you can going a bit, only then you talk about targeted if you got time. If you don't have time, you want to go straightforward, no problem. So you can, for Behçet's disease, very simple. You don't need to, you don't need to talk very detailed. You just need to mention that refer for rheumatology for initiation of DMARDs. And Behçet's disease is actually very systemic condition. And therefore, but for joint pain and skin, all those things, colchicine should be the first line. Okay. You almost mentioned that. Then I was like, are you going to mention that again? No, you didn't. But the colchicine is something you must mention. And you must consider things like steroid as a backbone. For Behçet's disease, I will show you a diagram that is very helpful. Behçet's disease actually different biologic agent or different DMARDs depending on the different organ involvement. Just treat it like a rheumatoid condition. But the baseline is you need to start patient on colchicine and the steroid. Steroid is the backbone for Behçet's disease. Okay, colchicine is also PRN or regular dose if patient have any joint pain. It tends to respond well with the colchicine, and therefore it can also explain why the GP so-called diagnosed as possible gout because patient actually responded a bit to the colchicine. Okay, this is also another clue to suggest this cannot be just gout. And then remember to also involve ophthalmologist because since you already identified that the patient got painful red ulcer in the past, also refer them for formal visual assessment. Okay, concern part I think you answer most of it. So just to go through a bit on the Behçet's disease. So you don't need to know all the phenotype. It's not important. Just need to know Behçet's disease is a form of vasculitis. And the common feature is actually a painful oral genital ulcer. Can also have eye ulcer as well, ocular disease especially, causing uveitis. and also vasculitis over the retinal lesion. And the skin is probably the earliest manifestation after the ulcer, in which you will expect some form of, sometimes can just be acne, sometimes can be just macular papular rash. And the commonest and the most pathognomonic is still the erythema nodosum. And then arthritis is usually asymmetrical, oligo, and then usually affect medium joints, but can affect large or small joint as well. And the vascular lesion is the thing that triggers you as well. Bear in mind that if you've got all this, usually we use things to screen, like for example, ulcer over the mouth, eyes, as well as private area, any rash over the skin, especially your shin, and any joint pain, and any clots in your leg or any veins in the past. So usually that's how we screen for Behçet's, right? And the diagnostic criteria is actually simple. It's not that difficult. You just need to know that a few criteria based on the symptom. So usually patient will have recurrent oral ulcer, okay, or not necessarily oral ulcer, sometimes can be eye ulcer as well, or even the private area. So must be like 3 episodes within like 1 year period, and 2 out of the 4 of the following, which is the genital ulcer, ocular, skin lesion like erythema nodosum, and abnormal pathology test. So you can see that actually for this patient already fulfilled. So patient can have intermittent recurrent ulcer, and also already one year, and also got genital ulcer, got eye involvement, and then also got erythema nodosum. So he already fulfilled Behçet's diagnostic criteria. Okay, so just to know the manifestation based on literature, you can see that the oral ulcer is perhaps the commonest. Perhaps just now I didn't want to give very easy for you. I say no ulcer. Actually, the more fairer, I mean the fairer way is actually to tell you the patient have ulcer intermittent. Okay, so you can see ulcer occur in almost all the patient, and genital ulcer is also very frequent, and then the erythema nodosum is at 50-50, and pathology reaction is only about 50 to 60. And then you can see that uveitis also very common, arthritis is also common. All these are common. Okay, DVT tends to be lesser, but it's something we need to keep in the back of our mind because it's a very frequent exam question. And then GI, CNS, all those things are not very common. Okay, so this is the photo or diagram that I want to share. So you can see that Behçet's management, actually the backbone is the glucocorticoid, which is a steroid. Okay, so steroid form the backbone of the treatment. And if you're talking about joint and skin involvement, you need to start patient on colchicine. Okay, and some other second line DMARDs like azathioprine and interferon or even etanercept. But then if patient presented with uveitis and with DVT, and like for this patient, definitely this patient got these two before, and this patient may need to consider starting azathioprine and also biologics already because got this involvement as well. If patient got CNS and GI, is considered severe, patient will need to start on biologic as well. And another spectrum is also like a bit of like, what would I say? A bit of pulmonary hemorrhage kind of spectrum, like RPGN or renal pulmonary syndrome kind of picture. Like for example, like good posture like that. So this kind of spectrum tends to be very aggressive. That's why you need to treat with cycle with AZA or cycle with steroid, okay, and the biologics. So basically, this is the general management of the Behçet's disease. Don't need to know in detail. Just need to know that the glucocorticoid form the backbone, and patient if got joint and skin involvement, you start the colchicine and consider biologics for as per end organ involvement. Okay, just need to mention like that. So another thing is I want to share. I think we shared during the last session, but I just mentioned in the previous session about the shin lesion. What are the possible differential diagnoses? Last time we talked about calciphylaxis, I remember, and that time can be also pyoderma gangrenosum. If there is a pseudomonas, that can be erythema gangrenosum. But the one that I actually highlighted in bold is the one that can commonly come out in exam. Okay, those not in bold one probably not that common huh? But you just need to know if you have a shin or anterior shin lesion when you are preparing outside the scenario, what is your thoughts? What is your differential diagnosis? So definitely if they want to go easy on us, they can give us a case of cellulitis or statitis dermatitis. Okay, with the obesity, immobilization, that will be very easy. Okay, but the common kind of like basis favor will definitely be erythema nodosum, or even necrobiosis lymphatica in diabetic, or even pyoderma gangrenosum in association with IBD or DM or some autoimmune disease as well. And diabetic dermopathy is also common. Another last one perhaps is important is the pretibial mixed edema in a patient with thyroid disorder. Okay. Okay, that's a lot of noise, but never mind. Let's just continue. Other than that, prurigo nodularis can also occur, but not common. Usually suggest liver or kidney disease, some systemic disease. And Dr. RP just now asked about possible vasculitic rash, right? So vasculitic rash tends to appear like that. Okay, it's like patchy, nodular, and then usually confluent together like a red patch like that. So usually this is very vasculitic. If you look at this kind of rash, you know that this is probably patient have some form of vasculitis going on. So if vasculitis over the shin vasculitic rash, most common is actually the leukocytoplastic lah. And then probably the so-called end-stage kidney disease with tertiary hyperparathyroidism, you're talking about calciphylaxis. Okay, so this will be it for the differential analysis of huge shin lesion. So in terms of differential analysis of erythema nodosum, almost same as like how I approach to prolonged fever. I will go by autoimmune, infection, neoplastic, and drugs. But instead of putting infection at the first, I will put autoimmune as the first associated with erythema nodosum. Okay, so in terms of erythema nodosum, I would need to make sure I exclude IBD, SLE, Burchett's, and also sarcoidosis. Okay, so you can see that today we discussed like Burchett's disease and sarcoidosis. Both also have possibility to develop erythema nodosum. Okay, SLE and IBD is also something very common in association with EM. So infection-wise, both streptococcal infection, TB, okay, sometimes can be syphilis, fungal, or even like some other virus. Hepatitis is also can be associated as well. Neoplastic had to rule out myeloproliferative and lymphoproliferative disease as well. Drugs, very important. Common drugs that we need to know is actually the NSAID, ACE, and also the penicillin antibiotics. Okay, these are the common kind of antibiotics. Sometimes OCP can also cause erythema nodosum, but not common. And pregnancy is rare to cause erythema nodosum, but something keep in the back of our mind to give a differential. And sometimes half of it can be idiopathic. We don't know what's the cause because it comes and go until certain form of disease manifests later on. Okay, so with that, I think we will proceed with case 4. So anyone want to volunteer for case 4? If not, we will let Dr. Aki to try. Anyone wants to?
Hi,
Sorry,
my name is Darshini.
you're sorry, you're Dashini. Dashini, is it?
Yes.
Yeah,
Yes.
you're okay to try the last case?
Sure.
Okay, so I will give you 4 minutes. Are you ready to start?
Yes.
Okay, yeah. So let me just start the timer. Okay, you will start now. Okay, time's up. Dr. Dashini, this is the patient, Mr. George. Please start.
Right. Good evening, Mr. George. I'm Dr. Darshini. I'm the doctor in the medical admission unit. I understand that you've come with some complaints of chest pain. Can you tell me more about it?
Yeah, doctor, I've been having chest pain for almost 2 weeks now. It actually started at the right side of my chest. So I feel very, very discomfort, especially when I cough, doctor.
Okay, so the pain worsens when you cough.
Yeah, as well as when I breathe in and breathe out. When I breathe in, it tends to be worse.
All right, okay. Does it change with your posture?
Not really.
All right. How would you describe the pain? Is it stabbing or a dull pain?
It is like a pricking kind of pain.
Okay. And is it there throughout the day or does it come and go?
It is throughout the day.
Okay, all right. And did it start all of a sudden or did it start gradually 2 weeks ago?
It started gradually initially. I thought it's because probably I strained myself, but subsequently I realized that it has been persistent and getting worse.
Okay. On a scale of 0 to 10, how bad would you say the pain is?
I would say if I breathe in or if I cough, it actually can go up to 5 or 6 out of 10.
All right. I'm sorry to hear that. I hope that we'll be able to help you by the end of this conversation.
Oh, thank you.
Does it radiate anywhere else?
Not really. It just stay at the right side of my chest.
Okay. All right. Is it associated with any other symptoms like coughing?
Yeah. I have cough also for about 2 to 3 weeks like that.
Okay. Can you tell me more about the cough? Do you bring up any phlegm?
No, it's dry.
Okay. All right. And is there any particular time of the day where the cough is worse?
Yeah, I feel like if I lie down or if I towards the late evening or night when I cough, it tends to get worse. It tends to get worse.
All right. Have you had any raised body temperature as well?
Yeah, doctor. I also realized that I recently have high grade fever. I checked my body temperature. It ranged about 38 to 39 degree, especially at night.
Okay. And how long have you been having that?
It's almost also about 2 to 3 weeks.
Do you have any profuse sweating at night as well?
Yeah, doctor.
Okay. All right. Do you have any difficulty breathing?
Only if I walk a long distance, then I will feel a bit breathless. If I stay like now talking to you, I'm okay.
Okay. So how far could you walk? Could you walk up, say, 3 flights of stairs?
Sorry, how many flight of stairs?
3 flights of stairs?
3 flight of stairs. I think I can, but I need to slow down.
I see. Okay. All right. Apart from this, do you have any noisy breathing?
No,
Okay. Do you have any leg swelling?
no.
Do you have any racing and pacing of your heart?
Sometimes when I exert myself, when I walk a long distance, yes. When I rest, no.
Okay. All right. Do you have any difficulty lying flat and going to bed at night?
No,
Do you have any running nose?
no,
Any change in the appearance of your nose?
no.
Okay. Apart from this, do you have any? Did you do any heavy lifting recently?
Sorry, heavy lifting?
Yes.
No.
Okay. Do you have any sour acidic taste in your mouth?
No.
Okay. Do you feel any nausea?
You mean feeling sick? No.
Yes. Only feeling sick. Okay. All right. Have you had any recent pain in your legs?
No.
Okay. Have you had any uh, bruises anywhere on your body?
No.
Anyone told you you look more pale than before?
No.
Okay. Do you have any recent loss of weight?
Yeah. I actually for the recent 3 months, I realized that I lost about 10 kg.
Okay. Is this intentional?
No.
Okay. How is your appetite?
My appetite has equally reduced as well.
Okay. All right. Do you notice any lumps or bumps in your skin anywhere?
No.
How is your sleep otherwise?
Sleep. I still can sleep, just that sometimes I will wake up because of the high grade fever.
Do you notice any rash spots or pigmentation anywhere?
No.
Okay. All right. Do you notice any changes in your urine production?
No.
Is there any changes in your bowel motion?
No.
Any tummy pain?
No.
Tummy distension?
No.
Okay. Do you have any joint pains?
No.
Any back pain?
No.
Do you have any headaches?
No.
Any difficulty in moving your neck?
No.
Any weakness or numbness anywhere on your body?
No.
Do you notice that you prefer either hot temperatures or colder weathers?
I think for both I'm okay.
All right. Do you notice passing urine more frequently than before?
No.
All right. Okay. I would like to ask you, have you been admitted in the past?
Not admitted, but I visited my GP for about 2 times already, and they
Okay.
give me about 2 courses of antibiotic, 1 week each. But the symptom has been persistent.
I see. Do you know the names of the antibiotics?
I am not very sure, but I was told something about amoxicillin, and another one I think is 3 days duration, something called submicins.
Okay. All right. Have you had any surgeries in the past?
No.
Do you take any medication regularly?
Regular medication? No.
Any over-the-counter tablets or any herbal supplements or pills?
No.
Are you allergic to anything?
Not that I know of.
Are there any illnesses that run in your family?
No.
Sorry, I'd like to ask you some questions. They may seem rather personal, but it's important for me to get a diagnosis, if that's okay.
Sure.
Do you smoke?
Yeah, doctor. I smoke since young.
I see. How often do you smoke and how much?
I smoke about 1 pack for each day, almost more than 10 years now.
All right, Mr. George. Any amount of smoking is injurious to your health, so I'd like to advise you to stop smoking. If you have trouble with it, we can refer you to our smoking cessation clinic.
Okay.
Do you consume any alcohol?
No.
Are you working?
Yeah, I work as a tailor.
Right. And how has this affected your job?
Yeah, I can see that if when I sew clothes, even shirts, because of all this chest pain, I have difficulty to sit down for long. It really affects my work, doctor.
All right. I'm sorry to hear that. I hope that we'll be able to help you.
Hmm.
Have you taken any illicit or party drugs?
No. Hey, wait. You mean now? Now, no.
Anytime in the past?
Yeah, I have to admit that in the past, when I was young, I do try with injection of some medication through the needle with my childhood friends.
I see. All right. This was when you were much younger, is it?
Yeah, when I was 14 years old.
All right. Okay. And are you driving right now?
Yes.
Okay. Are you married?
No.
Any recent travels?
No.
Any contact with anyone who's unwell, or you know anyone who's got tuberculosis?
No, not that I know of.
Have you had any? Sorry to ask this question. Have you had any unprotected sexual relationships?
No, I am not in any relationship.
Okay. All right. Is it okay if I examine you, Mr. George?
Yeah, sure.
So I'd like to look at the peripheries. Any evidence of clubbing?
No.
Any? Hello.
Hello?
Yes.
Yeah, I can hear you.
Any evidence of pallor, jaundice?
No pallor or jaundice.
Any needle track marks over the forearms?
No needle track marks, but there's a tattoo over the right aspect of the deltoid.
Okay. Does he have any palpable cervical lymphadenopathy?
No.
Okay. I'd like to examine the lungs.
Mm-hmm.
I'd like to auscultate whether he has any evidence of any crepitation, cross crepitation, bronchial breath sounds.
There's no palpitation, there's no bronchial breath sound, but when you examine the patient, you notice the chest expansion over the right lower zone is reduced.
Okay. Is there any dullness on percussion?
Yes, it's down on percussion, and the breath sound is also reduced. Vocal resonance is also reduced.
All right. Okay. This is the right lower zone. Correct?
Yep.
Any evidence of hyperinflated chest?
No,
Okay. And he generally, his appearance, he's cachexia.
he is quite thin. You can see.
Okay. All right. Also like to auscultate the heart. Any murmurs?
No murmurs.
the apex beat is undisplaced?
Apex speed is normal.
Okay, all right. Um, and then, I also like to examine the abdomen, any organomegaly.
No organomegaly.
Okay, and also the inguinal and axillary lymph nodes.
Examiner say you can skip, but generally there's no palpable inguinal lymph nodes.
Okay, all right. So I'd like to ask Mr. George, what are your concerns?
Yeah, doctor. I'm actually do I need to be admitted? I've been having these symptoms for very long and very worried.
All right, Mr. George. Yes, at this point of time, I believe it would be best for us to admit you because you've been having these symptoms for more than 2 weeks, and we would like to investigate you and start treatment immediately if possible.
Oh, what am I having, doctor?
Okay, so at this point of time, Mr. George, there are a few things running
Is
through my
left?
mind. There are a few things running through my mind, and one of it would be whether or not you have an infection which is known as tuberculosis. This is an infection that can affect your lungs and can cause an infection which would need a long-term treatment. There are also other things that we would need to rule out because you've had a history of trying drugs when you were younger.
Oh, what you mean by that, doctor? Are you suspecting anything else?
Yes, because you've had a history of using drugs through a line when you were younger, there is a risk of developing other diseases such as HIV. I hope you're not too
Oh,
alarmed. We would just need to do a testing on you to ensure that you're not experiencing this condition.
can this be lung cancer, doctor?
At this point of time, based on the duration of the symptoms that you're experiencing and some other things that I found in your history, I do not think this is lung cancer. However, if all the other investigation results comes back negative, then this is something that we would consider, but it's very unlikely.
Okay, doctor, if I have this so-called tuberculosis, will I spread this to my colleague if I want to resume my work?
Yes, at this point of time, if you do have active tuberculosis of the lung, we will need you to take medication, and at least for the first 2 weeks, you will need to be in isolation. After these 2 weeks, if we test your phlegm sample again and it turns out to be negative, then you can resume work.
Oh, okay. And will you disclose my condition to my employer? I refuse to let them know.
I see. Okay, so Mr. George, the thing is that this disease is a notifiable disease, which means that we will inform the health authorities regarding this. However, if you are on a medical certificate and you are in isolation and you're not exposing anybody else to this condition, then we would not need to inform your superiors regarding this. However, all those in contact with you do need to be tested. So I believe that they will be aware of this condition,
Okay,
unfortunately.
doctor. Okay, doctor. Time's up. Okay, so Dr. Tashini, would you mind to tell me your differential diagnosis and your provisional diagnosis for this patient?
Okay, so my provisional diagnosis in this gentleman is pulmonary tuberculosis, possibly complicated with pleural tuberculosis as well. Other differentials that I would consider in this patient includes possible pneumocystic pneumocystic infection with underlying retroviral disease. Other differentials that I would also consider includes other
Hmm.
non-tuberculous mycobacterial infection.
What is your clinical finding for this patient?
Clinical finding is a right lower zone collapse,
Collapse?
possible
Have you,
collapse or effusion because he has reduced breath sounds and reduced vocal resonance with reduced chest expansion.
so
So it
how
could
do you
be
differentiate between these two?
so pleural effusion. In a collapse, I would expect the trachea to be deviated, and since it is a lower zone, it is more likely to be a pleural effusion.
But have you checked for tracheal deviation?
No, I did not.
Let's say this is a effusion. So what is your diagnosis for this patient and the differential?
It would be pleural tuberculosis. Other differentials that I would consider would include parapneumonic effusion with
You would expect like a simple parapneumonic effusion, or this is something like complicated?
complicated, definitely, with the persistent symptoms for more than 2 weeks.
Mm-hmm.
I'll
Any other?
consider some NTM organisms or MDRO organisms.
Okay. Like, let's say more severe than complicated pulmonary effusion. Anything else that's possible?
Lung empyema.
Okay, good. How will you investigate this patient?
So I'd like to investigate this patient by doing a full blood count to look for evidence of leukocytosis, a baseline renal function and a liver function test. I would also like to do an ESR and a CRP to look for raised inflammatory markers. I would then like to do a sputum analysis, which includes a sputum culture, a sputum acid fast bacilli, as well as MTB culture. Apart from that, this patient required chest X-ray to confirm the diagnosis of pleural effusion, as well as a ultrasound thorax and a diagnostic pleural tapping. I would like to send the pleural fluid for analysis, which includes FEME, cell count, gram stain and culture, as well as ADA and gene expert. Apart from that,
Yes,
apart from
about
that, I would like to do a retroviral screening for this gentleman due to the history of intravenous drug abuse previously. I would also like to do a baseline ECG to ensure that we're not dealing with a cardiac condition.
okay. Anything else?
A MEN2 test.
Mental test. Okay. So other than RBD screening, is there any other infectious screening you want to order as well?
Hepatitis B and C.
Okay, sure. So let's say that the sputum workup for AFB is negative, and didn't manage to send a gene expert, and the pleural AFB is also negative.
Okay.
And is there any way to confirm the diagnosis of TB?
You could also consider a bronchoscopy with a bronchoalveolar lavage or a pleuroscopy and a biopsy to look
Okay.
for caseating granuloma or a positive gram stain or a culture.
So let's say that this patient HIV test turned out to be positive, and with the same scenario, and the bronchoscopy survey is not available. Is there any test that you can do to confirm the diagnosis of TB?
I could do a IGRA, but it is more important to detect latent TB.
Okay. So now, okay, never mind. How will you manage this patient, knowing that all the things that we have discussed?
All right. Okay. So I'd like to manage this patient both via pharmacological and non-pharmacological measures. Via non-pharmacological measures, I would like to educate and counsel him regarding the disease. If this is a tuberculosis, then I would need to notify this condition and contact tracing for the people who have been in close contact with him. Apart from that, I would also like to advise him for smoking cessation. And the management of this patient would require a multidisciplinary team approach with a physiotherapist for a pulmonary rehabilitation, occupational therapist for workplace modifications, and a pulmonologist. He would require anti-TB medication. So if this is a pleural TB, then I'd consider an intensive phase of treatment for 2 months and a continuation phase for 5 months. This would include the intensive phase drug regime would include rifampicin and isoniazid, whereas the continuation phase would also require an addition of pyrazinamide and ethambutol. During routine follow-up, after 2 weeks, he would require a reassessment chest X-ray.
Yeah, but you can continue.
Reassessment chest X-ray and sputum analysis to ensure that we have achieved sputum conversion. If this patient has concomitant RVD, then I would also like to treat him for HIV by referring him to our infectious disease team and starting him on highly active antiretroviral therapy.
So the question is, how long do you consider starting the antiretroviral therapy after you start anti-TB?
I think after the intensive phase.
After intensive phase, that means 2 months.
No, after the reassessment in 2 weeks. I'm not too sure.
Okay, all right. So what does the WHO guideline says about this? Do you know?
No, I'm not sure.
Yeah, so the WHO says that, let's say that the patient has co-infection, already co-infection with pulmonary tuberculosis. So the guideline is used to say that you start the anti-TB, and then you should initiate ART within 8 weeks of therapy. Okay, there's a 2 caveat for this. Okay, that means within 2 months you need to start treating for the RVD. But But there's two caveat for this. Okay. So first caveat is if let's say the CD4 count is very low, like CD4 less than 50, then you need to start the ART within 2 weeks of after starting anti-TB. Okay, this is the first caveat in which you start early, which is within 2 weeks. And there's a second caveat that you need to really consider start antiretroviral therapy only after you complete intensive phase of anti-TB, which is 2 months, which is 8 weeks. That's only for TB meningitis. Okay, so TB meningitis will be after 8 weeks. CD4 less than 40 will be 2 weeks, and anything in between is actually within 8 weeks. Okay, you should start depending on the patient condition. And any reason why we are having this this so-called protocol? Do you know? What is the reason we cannot start too early or too late?
I'm not too sure.
If it's like what will happen if you start the ART too early after you start the anti-TB?
Or they develop a hyperinflammatory condition.
What does this condition called?
I forgot.
Yeah, it always happen when in exam, right? Yeah, it's iris. Immune reconstitutional inflammatory syndrome. So iris, another thing about iris is, so the history can give something like after start the anti-TB, patient is well and suddenly become unwell. This paradoxical worsening in terms of symptom. And this iris can manifest in a various way. It can manifest as suddenly got lumps and bumps, new lymph node palpable. It can also manifest as some form of liver injury or some form of cytopenia. So all this need to be monitored. Okay. And there's only one thing. I think your discussion is very good. You are very good. I think you are very fluent. And there's only one thing that I want to add on in your management. This is a respiratory case, right? I mean TB and then curing HIV. So other than stop smoking, physio rehabilitation, so other than referring to chest physician and start anti-TB, you also need to mention about vaccination. Okay. So for him, you will definitely need a pneumococcal influenza vaccination or even COVID vaccination. Do you know how frequent you need to give the pneumococcal vaccination for this patient? Let's say it's RVD positive.
5 yearly as well.
Brief
5
of it.
yearly.
5 yearly. No. 5 yearly is the old guideline. Now no one give 5 yearly things already. Okay. So the new guideline says that I mean for Malaysia, okay, because for other country got different vaccine. We only got PCV13 and PPV23, right? Okay. So either you give 13 or 23. Okay. So the principle is in a non-immunocompromised patient, you can give either one. You can give PCV or you can give PPV23. But the guide is that PCV13 you only need to give once in a lifetime. Okay. So meaning to say that let's say patient less than 55 years old or less than 60 years old, we generally consider 55 years old as a so-called as a cut-off as elderly. Some they consider 60, some they consider 65. Let's say you're less than 60 or less than 55, you got lung disease, you got risk factor, you should give the pneumococcal vaccine, PCV. Either you want to give PCV13 or you want to give PPV23 first, is fine. But generally, if you give PCV13,
I'm Siri. How can I help you?
and the PPV23, you should only give after 1 year from the first dose. Okay. And then after you get the second dose, it's considered vaccinated until you become elderly. After you become elderly, you can consider giving another dose of PPV23. Okay, then you consider complete the vaccination. So meaning to say every people most of the time only receive 3 to 4 jabs of pneumococcal vaccine in the entire lifetime. It's not 5 yearly vaccination anymore. Okay, so this is the guideline. How about for RVD or immunocompromised patient like end-stage renal failure? So what we do is actually you should give PCV13 upon diagnosis or when patient is well enough for discharge, we see as outpatient, you can give PCV13. Then how long before you can give a second dose of vaccine, which is PPV23? Do you know?
No.
So instead of 1 year, like I mentioned, for a normal population, it's 8 weeks. Okay. For those immunocompromised patients, you can give the vaccination gap reduced to 8 weeks. That means 2 months after the first jab. So PCV13, you give after 8 weeks, you give PPV23. Okay, and if patient needed booster, you can give another PPV23 only after so-called 1 year duration. But let's say you give the patient this patient, if let's say you give RBD patient, you give PPV23 first, you cannot wait for 8 weeks, then you straight away jab the PCV13. It doesn't work that way because the reason is being it will actually reduce efficacy. So generally we give PCV13, 8 weeks, and then PPV. But let's say you already give the PPV as the first dose, then you need to wait, unfortunately, you need to wait for 1 year before you give the PCV13. And generally PCV13 you only give once for entire lifetime for a patient. Okay, you understand?
Yes.
Okay, so a few things. I think first is perhaps how do you find about this scenario? Do you have any thoughts about this scenario? Like any question or any things that you want to ask?
No.
No.
Was it meant to be a lung empyema?
Sorry?
Was the provisional meant to be a lung empyema?
No. The provisional diagnosis is TB, it's pure TB. But always a possibility of empyema thoracis, because it's a pleural effusion, right? And it's already for 2 to 3 weeks already. Need to suspect empyema. That's for sure. And how will you comment in terms of your performance?
I was very nervous, so
Yeah, I can see you're nervous because
talking very fast.
your speech become very pressured.
Yeah.
So some examiner will like your style in which you speak fast, give answer fast, everything is fast. But sometimes a lot of people, you can imagine if you went to mock a few times before this, I believe,
Yes,
or
I've
even
been.
any teaching, you saw most of the examiner that they recruited, they hired is quite old already, right?
Yes.
Yeah, so you may need to tune down a bit, especially if you kena Dato Q, or she'll be like, sorry. After you say like 20 sentence, she'll be like, sorry, what do you say? Then you'll be even more nervous. So sometimes you need to be a bit slower. So I usually advise people to speak a bit fast, but yours one is the opposite. You need to slow down a bit because slowing down will shows that you are a bit more calm. At the same time, slowing down will give you more time to think. Because I can see that your thought process are very fast. That's good because you genuinely need maybe one or two extra seconds to think about another answer when you answer the question. So you perhaps it's also good for you to slow down a bit. And your history is good. You got most of the things. Okay, I will just go through. If I'm going to mark you, I think you can get all full marks. I got no question on that. Okay. So, but there's a few things I want to mention. In terms of history, I think you got most of the thing. And seek contact, TB, but actually, have you asked anything in particular to rule out TB other than night sweat and the fever and the cough?
No, actually, I only asked those 3 questions and seek contact with TB.
So how about hemoptysis? You didn't ask about coughing or breath, right? I remember.
No, I didn't.
So that's another important thing that you need to ask as well. Let's say patient with TB come in with hemoptysis, what is your possible differential diagnosis?
Whether it's a TB causing bronchiectasis now presenting with hemoptysis.
Post-TB bronchiectasis, right? Okay, good. Let's say, how about any other differential?
No.
So another thing you always need to suspect is, let's say patient is being treated and now coming in hemoptysis, you always need to suspect recurrent TB, recurrent TB or drug-resistant TB, okay? And the third possibility is, do you know any association with lung pathology with PTB, like those advanced PTB, that can actually cause quite a life-threatening hemoptysis?
No.
Not sure, right?
No.
Have you heard about something called Rasmussen aneurysm?
No.
Yeah, basically it's an abnormal airway dilatation that predisposed to bleeding. It's a Rasmussen aneurysm, but it's not common. But it can happen in patients with advanced TB. So something that you need to take note as well. So other than that, I think most of it is considered covered. And I know that you ask the patient what as a tailor, but you also need to ask about any soil contact, any wound contact. That will actually try to elicit that can this be some form of infection, like so-called MSSA infection or any form of atypical infection. that you get that therefore can cause the empyema thoracis. Let's say this is also another possibility that you need to ask. Okay, examination. I'm going to fault you for one thing only, or perhaps two things. For this case, you need to check for the BCG scar because you're already suspecting TB. No? Okay, so this is the first thing. Second thing is you must really, I have to repeat 3 times. You must check the oral cavity.
Okay.
The reason is being TB is always a good brother and sister to TB. Sorry, to HIV, right? And if you suspect HIV, you really need to check HIV, check for HIV, not only in terms of the history for the risk factor and also the examination. You must check for oral thrush. If you ask to check, if you check, I would say this patient actually got oral thrush. And the moment you saw oral thrush, you know that this cannot be just TB. This must be TB with RVD already, right? Because CD4 less than 200 only you have the oral candidiasis. Okay, so you know that the patient is immunocompromised. And my question is why the patient don't have bronchial bleeding in your lung examination finding?
Because of the effusion, it's obscured. Or it's an early stage of TB.
Okay, can be early stage of TB. And but let's say there's no cavitation at all. In this patient, are you surprised?
No, sometimes RVD patients present differently.
Correct. Atypical presentation. Immunocompromised, not only RAD patient, all the immunocompromised patient, including very young pediatric patient, or even those patients with end-stage renal failure, or those patients that on immunosuppression therapy, they usually don't have cavitation because their immune system is so compromised, they cannot even form a gone focus. There's no cavitation at all. Cannot form the granuloma, you know. So that's why the presentation can be a bit atypical. Like this patient actually is a right pleural effusion kind of scenario, right? So that's why you need to suspect that. Another thing is actually always try to make an effort to look for any chest wall tenderness. I know that usually we will look hard for any scar, we'll palpate, right? But usually you also need to try to elicit whether there's any chest wall tenderness. Because empyema can actually seep out, okay? If let's say this is the empyema thoracis, it can actually seep out into the intercostal muscle layer and form a lump over the subcutaneous layer, what we call as empyema necessitans. Okay, this is one of the complications for empyema. So also need to check for chest wall tenderness. But to me, this is like a soft sign. The hard sign to me will be lung examination, lymph node examination, tattoo marks, BCG scar, and also the oral cavity. Okay, this is a hard sign that you really need to check. Okay, investigation. I think you mentioned all. You mentioned also about PCP initially, and if you suspect, yes, you can send a sputum IF, immunofluorescence to look for that, diagnostic tab, everything. And I asked you one question just now. So in RVD patient, sometimes the sputum yield is very low. Pleural yield, TB culture, AFB, all also very low. So what is the test that actually can diagnose TB in an RVD patient fast? It's actually this what was urine lamp. Okay,
Yeah.
you heard about urine lamp before?
Yeah, we've done it before. I completely forgot about it.
You done it before. Which
Yeah.
center you have done it?
It's from Ban Hospital.
Oh, you all have urine lamp already, yeah?
Yes.
Okay, that's good because not many center have actually. So urine lamp is something very new. It's something that is very useful because it is not infectious. Urine lamp basically just detect the mycobacterial cell wall, And the reason why it is actually is only advocate in patient with RVD or immunocompromised. Okay, the reason is being because immunocompromised patient cannot form cavitation, cannot form granuloma. So all this mycobacterial cell wall cannot be broken down. So all therefore this cell wall can be detected in the urine. That's why it's very easy. You just send the urine lamp. If it's positive, then you treat as TB. Okay, so it is different compared to latent TB. Latent TB is based on IGRA. And mantus, actually, you can forget about mantus in RVD patient. But for IGRA positive, even if IGRA positive, even if IGRA negative, also we will definitely treat patient as latent TB. The teaching is ideally in every RVD patient, you should treat for latent TB. Okay, when the patient is stable, that is the ideal teaching. So meaning to say the IGRA is not important, the mantus is not important if you want to know whether the patient have latent TB or not, because regardless whether the result positive or negative, you're going to treat the patient as latent TB. The only difference is whether you want to treat the patient as active TB, and that comes with experience and also the gene expert. If those are not or inconclusive or so-called negative, and you suspect, you should send a urine lamp. Urine lamp is very sensitive and specific, and this is a form of new technology. That's why I need to share with everyone, because certain people, if your examiner is like a chest physician, taking this kind of scenario, they may ask you, so any other methods other than bronch, other than send for lymph node biopsy, other than all this. Another thing about this scenario is because patient already got TB pleural. So TB pleural, you need to suspect this is a disseminated TB. So you may need to consider a role of CT tap, okay? But not in all patients. Not all patients with pleural TB, we need to do CT tap, but that depends on the overall picture, whether there's any other organ involvement or not, okay? Because that will affect the duration of the anti-TB, okay? So I think that's all. Yeah, I've mentioned about the ART thing, the CD4 8 weeks, 2 weeks thingy. Anyone have any other question? Dashini, you have any question?
No, thank you.
Okay, yeah, thanks. So I think January to tonight is quite fast, huh? Everyone settle everything quite fast. I just want to show one photo before we end our session. This is what we call as empyema necessitans. You can see there's a lump there, huh? At the back, right back. So this is actually what we call as the difficult empyema that actually sit up. Okay, it forms a abscess over the skin region at the chest wall. So it's also important when you suspect any form of pleural effusion, you want to look out any form of complicated pneumonic effusion or empyema. You should also check for whether there's any chest wall tenderness. Okay, so if everyone got no question, then we will just end our session today. Is it okay? Okay, thank you everyone for joining. Yeah, so I think all the candidates today are very good. I would say, to me, actually, when I prepared this 4 scenario, I anticipate that people are going to tell me, "Oh, you prepared very tough scenario." So, but I'm quite surprised that, other than the first case, most of the remaining 3 cases, all the candidates get the diagnosis and manage to go through a good discussion. So I would say that everyone seems to improve. Okay, but I cannot tutor everyone like personally. Unfortunately, I can only do this kind of campfire session as per PRM basis. But I can see that everyone seems to know a lot already, and therefore things that we discuss sometimes can be a bit, I would say, advanced or a bit less common. But if you are already trained in this approach, if you're already very familiar with your history taking and your approach, any scenario when you come out in real exam, you will be manageable. And the more easier the scenario is, perhaps you will feel more comfortable to perform. So don't worry when you practice. Just keep on practicing. If you encounter any difficult scenario, if you don't know whether it can come out in exam or not, you can ask in the group or even ask me personally. But bear in mind that the RCP scenario are those that I included in my books, in my notes. So those are the one that can come out. Okay. So with that,